Okay, good morning and welcome to our public convening entitled Fostering Collaboration to Advance Representative Enrollment in Clinical Trials. My name is Trevin Luck. I'm an Assistant Research Director here at the Duke-Margolis Institute for Health Policy, part of Duke University. We're excited to have you all with us today. The goal of this workshop is to continue a conversation we began publicly last July discussing how to advance representativeness in clinical trials. Today, we'd like to continue that discussion, specifically looking at how collaboration between stakeholder groups can be used to advance clinical trial representativeness. We are far from the only one having this conversation, and we'll be joined today by some fantastic panelists that'll bring their perspectives and their experience working on this issue to help us with some good discussions to come. The discussions today also, while not a direct follow-on, will also extend to good discussions that took place last week at a different Duke-Margolis event on innovative clinical trial approaches you can find on our website. Among other topics, that event last week covered shared recognition of the need to bridge gaps between clinical care and clinical research, and the need to harmonize existing efforts and systems to ensure that both trials can inform care and we can bring new treatments to a broad range of patients. That event also showed as a ripe time for exploring the use of new technologies and frameworks to leverage EHR data and extrapolate it for research, while also building more and better room for engagement with patient and community groups as critical partners for innovation. That workshop did also touch on issues we'll get to today on representation, workforce gaps, diversity action plans, and related topics. But we'll be digging into all of those throughout our conversations today. Here at Margolis, we're very excited for the future of clinical trial innovation and the opportunities to extend trials beyond traditional healthcare and academic medical center settings into the community. But we know it won't be as simple as kind of porting over the traditional trial model into new venues. But before we get into all of that discussion, a few logistical notes. So first, as many of you that have maybe been to our events before know, the Duke-Margolis Institute for Health Policy is part of Duke University. And as such, we honor the tradition of academic independence on behalf of faculty and scholars and students. Neither the university nor us here at Duke-Margolis take partisan positions, but we encourage individual members and the guests with us today to speak their minds and express their opinions on the important issues that we'll be talking about. I think next slide. Quick overview of our agenda today. I will open with a short presentation to describe a little bit about the work and the thinking that we've done here at Duke-Margolis. And then we have several very exciting sessions to get to. First, we'll be hearing from a fantastic panel of community engagement experts. And after a short break, we'll then go into a great panel on learning about the role of innovative clinical trial infrastructure to help address representativeness in clinical research. After a slightly longer break, we'll then come back into covering funding considerations, business considerations, and kind of the economical piece of this conversation to get to success. And then we'll have one last session from a variety of perspectives, kind of looking forward as to what more we all need to be thinking about and working on this topic. I think just one or two more slides, and then we'll get into content. Support for this event was provided by the Robert Wood Johnson Foundation. We're grateful for that support, but do need to acknowledge that the views expressed here do not necessarily reflect the views of the foundation. As we know you're all interested, the slides and the recording for this event will be available on our website probably sometime next week. On our website now, you should be able to find both the agenda I just reviewed as well as biographies and headshots for all of our great speakers today. Next slide. Throughout the event today, we will be using Slido to facilitate questions. So we encourage you to either go on your browser to slido.com and input this code, DMI trials, or to use a device like a phone to scan your QR code, and that'll take you to the same spot. There throughout the day, feel free to ask questions of our panels and our speakers, and we'll do our best to get to as many as possible. We are expecting a pretty decently sized audience today, so we can't guarantee we'll get to all questions, but we'll do our best. Also, throughout several of our sessions, we will be asking all of you to contribute to the conversation by responding to some Slido polls throughout the day. We do want all of our discussions to be engaging and interactive, so we'll try our best to incorporate your questions and your perspectives throughout our discussions today. To get started, we have a test question that'll both help us know a little bit about who's with us today and help you all to kind of get set up on Slido. So before we get into content, please do let us know which of these sectors here best represents where you're joining us from. I'll give folks just a few minutes to get that in. I think as we probably would have expected, a pretty wide-ranging group. I see some responses are still trickling in. I think this might be open for a little bit, but mostly we wanted here to give us a sense of who we had with us and make sure you all kind of had the Slido connection set up. So thank you for responding. We'll be using this throughout the day to ask more topical questions throughout our next several sessions. And again, we'll also be using Slido to take your questions. So you should see in the same spot space to send questions our way. Okay. I think with that, we'll move right into our opening presentation. So I don't think if you're here with us that you need me to tell you that there's major gaps still in our ability to have representative clinical trials. We've seen some improvements in some ways, but despite a growing body of work by many of the folks that we'll have with us throughout the event today, there's still major gaps. But we do know those gaps around trust and bias and access. And so I think those will be coming with us throughout the conversation today, but we really want to spend our time together today on solutions and actions and the power of intentional multi-stakeholder collaboration. If you're interested in reading more about some of the challenges in the space, there are a wealth of resources online. We can maybe try to drop some of those in the chats throughout the conversations today. Many of our panelists have done a lot of great work on these topics. Meanwhile, there's also a push to reimagine clinical trial conduct, leveraging a more modern trial infrastructure. So things like pragmatic, decentralized point-of-care trials that do more to integrate clinical care and do clinical research. But these are newer approaches or approaches that have been thought about for a long time, but maybe not always successfully implemented. So there's more work to do to figure out what we want that to look like. So we think by integrating leading community engagement practices with this robust modern infrastructure and supportive funding and investment, we can develop trials that are more inclusive, accessible, and impactful. Next slide. But before we get too far, what exactly do we mean by representation? So this is how we here at Margolis have been thinking about it. If you have differences of opinion or think we've missed a key facet, we'd love to kind of hear from you on that. But for the purposes of today's meeting, when we talk about representation and representativeness, we're talking about an equitable clinical research infrastructure that is comprised of trials and other studies that accurately match the demographics of the disease burden for the disease being studied. These trials should be adequately powered to answer meaningful questions about safety and efficacy in underrepresented subpopulations. So not just trying to hit, a certain target that might not actually give us the information we need, but truly intentionally making sure that we can make meaningful decisions with the data we get from representative trials. And very importantly, clinical research should be a two-way street with patients and communities contributing to research question identification and prioritizing what matters to them. Next slide. As I've already hinted at, there's a ton of work happening in this space. This slide is capturing just a few pieces of that. Most importantly, as you may know, the federal government at the end of 2022 passed FDORA, giving FDA and in part authority to require drug sponsors to submit diversity action plans for their trials. There's some guidance out from this already before the legislation passed, but we're expecting updated guidance in the near future from the FDA on these action plans that should contribute a lot to thinking about how we really get representativeness in our trials for regulatory decision making. A few years ago, Congress passed another piece of legislation that requires all Medicaid programs to cover routine costs associated with qualifying clinical trials that went into effect recently. So this is expanding other requirements that Medicare and private insurers also cover most routine costs. In recent years, National Academies released a seminal report on representation in clinical trials and research that offered several recommendations and compiled a lot of great work on this topic. Our colleagues at the Clinical Trial Transformation Institute just last year released their own recommendations and a corresponding maturity model for sites and other stakeholders that are interested in improving diversity in clinical trials. The Multi-Regional Clinical Trials Center at Harvard has also released several interrelated resources to support more diverse and inclusive representation. And folks that we'll have with us today, and I'm sure many of you joining from the audience, from sponsors, payers, journals, and other stakeholders have engaged in a lot of efforts in their own ways to increase trial representation as well. So a lot of activity in the space. We'll try our best to kind of collate that and find the synergies today. Next slide. So as I mentioned, we've been working on this here at Margolis for a little while. You may have joined us for an event we held last summer with a similar title that looked at how we define what good representation looks like, how we build capacity for representative trials in community settings, and what should expectations for major stakeholders be. So both that meeting and this meeting have been informed by stakeholder interviews we conducted, literature research we conducted. So the conversations today will be helping us put the finishing touches on a couple of papers that we have in works that'll be out in the coming weeks, published here from Duke-Margolis Institute. Next slide. But today we want to move the conversation forward. So types of questions at a high level that we hope our panels will cover today include, what further actions are required? We've been doing all this work in this space in different pieces. What more do we still need? And importantly, how do we measure the success of those actions? Are there metrics or other things we need to be considering so that we really, when we see success, we know that it is truly success. Also, how do we make sure those approaches are sustainable and scalable? Success in small ways may not matter if we can't figure out how to scale that and make it sustainable over the long term. We don't want to see, one trial getting it right and then that infrastructure and approaches falling apart and it having to be rebuilt over and over. And very importantly, who is responsible for investing the time and the resources to make those actions feasible? There's some resources around, but where are we looking for the real contributions here to make the actions we know are necessary happen. Next slide. We've built our thinking and one of our papers and the agenda today around three what we're calling shared goals. So the first of those is moving beyond targeted or limited community outreach towards real, sustainable, continual community engagement. The other is building and scaling innovative clinical trial infrastructure to support that engagement. And integrating clinical research into care where appropriate, and then exploring funding strategies and other considerations to increase representativeness in clinical trials. So I'm going to go through each of these quickly, and then all of our panels will have longer discussions on these three topics. Next slide. On the community engagement front, the role of community outreach in driving improved health outcomes is widely acknowledged. However, in our work, we've seen that there's still a lack of sustained community engagement that lasts above and beyond, getting one trial through or things like that. Community engagement involves building relationships within a community to foster trust, community building, and investment in local initiatives. There's a need to identify and adopt standards for community engagement that promote that sustainability and scalability. And we really want to set the conversation today with community engagement as a foundation that we can provide support to provide support for the other aspects of representative clinical trials and make sure we're having the highest amount of impact. Next slide. Moving on from there to the infrastructure piece. Traditional clinical trials, while certainly a gold standard for evidence generation, are often also exclusive in several ways, whether it's inclusion-exclusion criteria still being too strict, or it being hard to access these traditional trials because people are far away from an academic center, or there are other barriers. As more pragmatic trial approaches proliferate, we see opportunities to make clinical research more accessible to more people, while still generating relevant, reliable evidence about real-world populations. However, the infrastructure to power these trials is still fragmented and in development. So we see a need for sustained investment to create robust, innovative trial infrastructure that is intentionally designed to make clinical research more accessible. Which brings me to the next slide. True success in achieving representative trials is going to require sustained investment in these areas, community engagement, trial infrastructure, workforce development, and more. Government and private industry are the ones with the biggest pocketbooks, so likely that's where the bulk of this investment will need to potentially come from. We hope to make the case that to drive that investment, that there is business models, there's business cases, there's an economical argument here that can showcase the potential value of investing in support for representative clinical research. But more work needs to be done there, I think, to truly show this case. But there is some evidence that suggests, for example, that intentionally prioritizing representative enrollment as you're starting up a new trial is not any slower, despite preconceived notions, than traditional not intentionally representative enrollment strategies. Next slide. Before I turn it over to our first panel, just one last acknowledgement here. As I've teed up, we're going to discuss what we think are many of the most important topics around representative clinical trials in our panels today. However, we want to acknowledge that there are many additional systemic issues throughout our healthcare system that have an impact on this conversation, such as lack of insurance or access to healthcare at all, language barriers, lack of time or resources, and more. So we're not going to try to say that our work or the conversations today will address all of the issues, solve all of the problems, because some of them are bigger than the clinical research, clinical trial conversation. But we think that there is a lot of work that can be done by the great folks that we have with us today and others to make clinical research more representative and hopefully lessons learned from this will filter toward other aspects of our healthcare system as well. One final note, getting back to a point I said before, we don't want to present this issue as a simple checking the box or a numbers game. We think truly representative trials are going to require addressing concerns of potential participants in those trials, both patients and providers, involving a diverse enough population that trials are powered to make informed decisions beyond just the high-level population look, and fostering bidirectional relationships between sponsors and participants and other key stakeholders here. So a lot of work to still do, a lot of promising activity, and looking forward to some really great conversations today. And so I think now I will be turning it over to our first session, moving beyond targeted outreach towards continual community engagement. This session is going to be moderated by my colleague, Sandra Yanka, postdoctoral research associate here at the Duke-Margolis Institute. And Sandra, take it away.
Thank you for that introduction, Trevin, and good morning, everyone. To kick us off, we're going to put up our next Slido question. What is one word that comes to mind when you think of meaningful and lasting community engagement? While you're submitting your responses, I'd like to introduce the panelists for this session. Afterwards, we'll begin with a brief commentary from Andrea Toomey before each panelist's opening remarks. The first panelist I would like to introduce is Nadine Barrett, Professor of Public Health Sciences and Senior Associate Dean for Community Engagement and Equity in Research at Atrium Health and Wake Forest University School of Medicine. We'll also hear from Bridget McCullough, founder and CEO of Akira Health, PBC, as well as Perla Nunez, Director of Perla Nunez Consulting, and Silas Buchanan, founder and CEO of the Institute for eHealth Equity. Now we'll turn to the fifth member of our panel, Andrea Toomey, who is the Community Health and Equity Area Lead and Faculty Director of Health Equity Education at the Duke-Margolis Institute for Health Policy. Andrea?
Great. Thank you so much, Sandra. And I'm really excited for today's conversation. It's really a wonderful panel. So to begin, what I just wanted to do was to provide some framing remarks, really focused on community engagement and the value of community engagement in clinical trials. So when we first ask ourselves, what is community engagement? Often there's a conflation between community outreach and engagement itself. So typically outreach efforts may be one-off or less frequent activities that focus on seeking initial input or at the end of a clinical trial of disseminating final results. While this is a very important step, outreach alone is insufficient to be able to create reciprocal dialogue and relationship building compared to ongoing, genuine engagement throughout the design, implementation, and evaluation of clinical trials. And that's what we'll be talking about today. So one brief example is for populations who may have a different preferred language, it is critical to engage people early to not just translate material related to clinical trials, but to incorporate cultural nuances into the clinical trial design and the materials that come out of this. I also wanted to share a quick example of this since we have Dr. Barrett on the line. Last fall, we held a town hall for a project through the Duke CTSI, which was actually held in Spanish and having translation into English rather than Spanish. And that was the first time actually that we had this type of event where it was centered on the preferred language of the community members that we were seeking to engage, not on using English. So even doing a step like that of engaging people in their preferred language is a type of example that we'll be discussing today. And again, from an outreach perspective, a team might directly translate clinical trial materials from English to Spanish, but that may miss a step, including ongoing training and education, and also ensuring that materials themselves and the way that materials are communicated are done in the way that people want to hear and from where they want to hear that. And ongoing engagement itself facilitates the ability to be able to identify priorities, needs, as well as resource gaps that may fluctuate over time and also differ across population groups and setting. And then the next point too is about who is included in the term community. So even the term itself lacks a clear definition, which makes it harder to be able to set standards and guidelines around who is included when people refer to community engagement. So for example, you might encounter a situation where a team says that they have done community engagement, yet they don't have meaningful participation from members of the population groups that experience marginalization in different ways. In addition, we did want to provide a little bit of framing in the context of where we are today in the political climate. So multiple studies have shown the importance of patient-provider concordance to be able to build trust, and that leads to better health outcomes. And this is also important in the clinical trial space, given the need to be able to overcome well-known and established biases in healthcare that emerge in the clinical trial enterprise. However, today we must make note of the challenges to be able to ensure workforce diversity in clinical trials due to changing sentiments in the political climate. So efforts to improve inclusion and diversity are not just, or should not just focus on increasing the representativeness of clinical trials from the patient perspective, but also who is on the teams running clinical trials. And that will be needed to be able to advance the vision of representative clinical trials and really make this a sustainable effort. Next slide, please. So as reporting out from this the Slido, so what is one word that comes to mind when you think of meaningful and lasting community engagement? I want to see if we can see the results from that. Wonderful. So some of the key things coming up here are collaboration, trust, partnership, but also respect and equity and inclusion. And as you can see here, the term community engagement is really a term that means many things, but really is focused on trust and partnership and collaboration and really in the community. So today we'll be talking more about strategies and practical next steps for meaningful community engagement, both during and after clinical trials. And now I'll hand it over to Sandra.
Thank you so much for that insightful presentation, Andrea. We'll now turn to our other panelists for their opening remarks, starting with Nadine.
Thank you so much. And thanks again to everyone for inviting me to be a part of this incredible panel and this incredible day. Really important topic, and definitely something that we have a lot of opportunities to grow in as a country and even globally around this space. So as was said, I'm Nadine Barrett. I'm Senior Associate Dean of Equity in Research and Community Engagement at Wake Forest School of Medicine. And you know, when I think about some of the key things that's really important to me in my own work is that community engagement has always been like front and center in everything I've done. And I would actually go as far back as to my parents, my mother, my grandmother, in particular from the age of 8 or 9, always taught me about the importance of listening. Not so much talking, but listening and being able to really and truly engage with people, especially the elderly. They were particular when I was 6 and 7 to really listen to the elderly and listen to their insights and their experiences and their perspectives and ask them questions from a curious perspective. And so that really, to me, kind of shapes, I believe, what community engagement is. It creates a space and opportunity to listen, and particularly to those who are oftentimes marginalized, minoritized, and certainly not centered in our social culture norms and everyday life of what we as a society truly see as valuable or valuable people. And so for me, when I think about that work, it really kind of is what keeps me grounded in that space. That being said, then, when we think about community engagement, I think we have some great opportunities to be able to take our work to the next level. As Andrea highlighted, which I truly appreciate in the opening, is that we really do engage, and there's some work that's happening now more and more around community engagement. As we all see, the NIH has even now made many of the grants that they fund a requirement to have community outreach and engagement cores. But to the point, what does that truly mean when we look across our enterprises and our systems? What does that mean? What does that look like? What oftentimes happens is that we kind of look at these things in terms of how do we make sure that the community looks at our flyers and our brochures and make sure that our flyers and brochures really are respective of the population. That's important. That's critical. And I certainly am not underestimating or undervaluing the importance of that. But I do think that it's time for us as a country and as people who are focused in this space around clinical research and trials to take it a little bit deeper than having people simply look at flyers and think that that now is the end of that expertise and insights and wisdom that the community can bring. And so I think one of the charges for us is to really deepen those relationships. How are we really moving toward embedding our communities in our work, from our strategic priority setting as organizations to what it looks like to think about research questions, to our design, to even the interpretation of our findings, which oftentimes is a space in which community is certainly not as engaged as they need to be. And the reason why I highlight that in particular is because when we think about interpreting findings, what we end up doing then is reusing the same reasons why we think these findings are as they are. So we see disparities and we say these disparities. I could almost take my own guess. This is anecdotal, but I would anticipate, and particularly given the Slido results just now, it kind of may affirm it to some extent, although not statistically for any means. But I think that one of the things is that we tend to talk about this concept of trust. And yet, when we think about disparities in most publications, when we see racial disparities in particular, one of the key themes that always seems to come up in the interpretation of findings is these disparities exist because they don't trust. These are because they don't follow the system's guidelines. They're not adhering because they don't trust, or as Henrietta Lacks. And I'm not, or I'm Tuskegee, and I'm not by any means devaluing any of those things, because it's true, the community doesn't trust because we've not been trustworthy as institutions. So it's true, and I embrace that fully. It's rightly so, right? And the same thing that happens in a marriage is the same thing that happens between communities and academic health centers in this space. So I think that if you don't trust, you earn trust. You don't just get it, right? And so I think that that's really important. And I think part of that then is that if we have interpretation of findings and we see these outcomes and these decisions or implications of these studies saying specifically that people need to trust, or there's an issue with trust, what it does then is it continues the same bias that already exists in research, right? So when we think about, again, the research questions, who's designing that study, how that study moves forward, and the interpretation, the results, and the implications, we never really interrupt that process to say, hey, let's kind of ask the people who we're referring to in this paper what they think these findings mean. And what do they see as the potential opportunities? And likewise, then when we think about clinical trials and clinical research perspectives, participation, I think it's really important for us to deepen our relationships with our communities, to start going further in that work. And so that's one of the things that to me is a priority. And then we can start truly measuring, as was highlighted in the opening, what the metrics are. How do we know the community is actually making this incredible impact in shifting our studies, shifting our thinking around research and the research enterprise, and ultimately leading to more trust because they're involved in it. And so therefore, they're more likely to become ambassadors in that work when the work itself is trustworthy. I think the other piece that we can't ignore is that when we think about the challenges in our systems around implicit bias, assumptions, perceptions, there's plenty of studies that have highlighted that. And I'm not shocked, and none of us should have been when we started to see this happening in clinical research and trials, since it has been well documented for decades happening in the clinical setting. Why would we ever think it would not also be happening within the context of clinical research and trials? Implicit biases, assumptions of who can and cannot participate in a clinical research study. So I think that, again, we have an opportunity to, even with our research teams, to ensure one, diversity, but also ensure that our research teams are trained up in a way that authentically knows what it means to engage with the communities, and our diverse communities in particular, and marginalized and minoritized populations. So certainly the Just Ask training and other trainings that exist are critical to that type of work. But even in that training, the Just Ask training that I developed, it also has a huge component around community engagement. In fact, the very training itself was developed with the community. So I think it's really important, again, to ensure that our community voices are informing everything that we do. It's embedded in our strategic thinking, and not just by study. I think it was mentioned, I mentioned it earlier. I think it's important that we don't think about these things as one-offs, like, oh, we need to engage them in our study. No, they need to be engaged in our enterprise, in all of our organizations. Then our community experts and partners and collaborators should be embedded at that level, not just study specific, but across the board, and truly being able to see our community as partners, as colleagues, which I like to refer to my community partners as partners or my community colleagues, because they bring an expertise that without their insights, we will never close the gap in health disparities. We will never truly have the kind of diversity that we need in our studies, and therefore will not be able to accelerate discovery, research, and lead us to the space that we need to in terms of making sure we have the appropriate therapies, interventions, and engagement that we need to advance health equity in a truly meaningful manner. So I'll stop there because I know we have a great discussion to come, but those are the things that's passionate on my mind, and the things that's certainly passionate in terms of my research and my work. I have phenomenal partners who are fully embedded in almost everything I do. There's not a thing I can do without first saying, wait, have I engaged my community experts to ensure that what we're doing, one, is something that's important to them. Two, it's also something that we can really move forward with and start disrupting the social culture norms of inequities, and I would actually say systemic and structural racism that's embedded in research that we really have not truly unpacked yet. Really engaging our communities in that will lead us to the space that we really want to be as we think about health equity. So thank you.
Thank you so much, Nadine. Really looking forward to digging into a lot of those great points during our discussion. Next, we'll hear from Bridget.
Good morning, everyone. I'm very excited to be here. I'm beyond excited to be here. Nadine made some fabulous points, and I want to piggyback on one point that she made in regards to community engagement. I am the founder and CEO of Akira Health, which is a digital platform that focuses on recruiting African-American women to the platform, where we focus on getting them acclimated, understanding, educated, advocating on behalf of them to participate in clinical trials. But one of the things that we do very, very differently, and while a lot of the systems that are already out here work to some degree, we think of them as more than just simply a number or someone that's going to fill a slot and participate in a clinical trial, and then you have nothing more to do with them. When I think of community engagement, I think of integration into the system. I think of sustainability. And I think of community beyond what we traditionally look at when we think of a community, and particularly when we think of how do we engage the Black community. Oftentimes we go to the very traditional pillars in the Black community, which is vitally important: the Black church, Black organizations such as Greek organizations as fraternities and sororities, or Black large national community organizations such as the NAACP or the Urban League. I look at communities in a much broader sense of that, because in a community, what's there are art museums, fashion, retailers, all of that becomes a part of community. So one of the things that we do that we really depend on with Akira and engaging Black women and it's sustaining them into clinical research as an entire industry is partnering with art museums across the country, galleries across the country, fashion brands, luxury brands across the globe. And why did I choose to do this? In part because of my background. I'm a former professor of 19th century French art history and a curator. So we know in the museum world, you cannot survive by just merely having the wealthy donor who's going to sit on the board of trustees and maybe give $500,000 a year to sit on that board of trustees. We know that you have to have everyone that makes up that community where that museum sits in. It's city government, it's state government, it's federal government. Of course, it's the people that's going to come into that museum to visit and to admire that artwork. But it's also corporate America across the board of all the various facets of corporate America. So I looked at it, and when I came over into this space of law around clinical trials and regulations, bioethics around clinical trials, and particularly looking at the health disparities of Black women and how can I have an impact to make that better. My main thought was, how am I going to keep them healthy? How am I going to look at clinical trials as a part of a comprehensive healthcare program for Black women? Apart from getting an annual checkup, seeing a dentist 3 or 4 times a year, seeing your gynecologist, clinical trials should be a part of that. That's sustainability. But how do you create that sustainability? One, you have to deal with trust. So that's one of the other things that we do. But it's not taking that trust and putting the burden of that solely on the shoulders of Black women, that you've got to trust this system. And it's a system that's not necessarily even thinking about you. It's a system that can go on and function for decades without you even being a part of it, let alone participating in it. So what we do is bring all of these communities together to create engagement, sustainability, and integrating these relationships. And part of the way that we do it is by having people, we bring in what I call friends of Akira. They are people that help to proselytize what Akira is doing, why it's important for Black women to be in clinical trials. Some of those people that are part of our friends of Akira have been empowered to become ambassadors within the Black community. These are Black women, right? So these are the women who they are the mothers, they are the matriarchs, they are the wives, the daughters, the sisters that can talk to their family members, can talk to their girlfriends about being in clinical trials and why that's important. One of the things that has become amazingly successful for Akira is when you tell a Black woman that Advil that you're taking for a headache, that Tylenol that you are taking for menstrual cramps, wasn't designed with your body in mind at all. It was designed for a 175-pound middle-aged white man. It's like a rocket being sent off into the stratosphere because it immediately lets you know that I'm not even being considered, even with that, something that's just so common in our culture, Advil and Tylenol, that most of us, if not all of us, are taking periodically throughout a given month or a given year, that I'm not even thought of, that I wasn't even a part of the decision-making of when we're going to create this. So how do you make that happen? So the community that exists within Akira consists of researchers, doctors, oncologists, people in pharma, Black women, of course. So this is a part of the community. And on a regular, sustainable basis, we have events, salons, forums, engagement, where we sit down and discuss what does this mean to be in a clinical trial? How are they designed? Why is it important to have my input as a potential patient or potential participant in clinical trials? This is something that has to happen. It has to happen and to become a very integral part of the community itself, just as much as that community member's healthcare plan. I don't want to take up too much more time because I know I'll have an opportunity to speak more in details about sustainability and integration in the community and with clinical trials. So I want to just stop there.
Thank you so much, Bridget. Those are really important points to highlight, and really looking forward to digging more into them during our discussion. So we'll now turn to Perla.
Good morning, everyone, and thank you to Duke-Margolis for giving us this opportunity. And I want to echo everything that Nadine and Bridget said. It is so very true, everything they've said, and I don't want to repeat myself, but so my career has been in research, preclinical research and clinical. And I started working in community outreach during my time at Duke CTSI, where I actually met Dr. Barrett, and really going into the community and talking about what is clinical research, why is it important? But, you know, we talk about trust a lot, and that is so important. And trust doesn't happen overnight. We need to take the time to go into communities as many times as we need to, and taking baby steps, right? Showing that we are a trusted entity. And again, it doesn't happen overnight. And I can't say that enough, because what I see is that, you know, the expectation is that we can go into a community today and talk about a clinical trial and expect that by next week they are all on board to participate. And that is just not the case. It's going to take time, and we don't have to go into communities and talk about a specific study. We need to start from the beginning, right? Information is key, talking to communities in a way that is culturally sensitive, acceptable. Just being relatable to communities is so important. And, you know, inviting them to give us their opinions about what they think, and actually listening to what they're saying to us. So I think that's very important, and I continue to advocate for that. I consult now, and I consult with organizations that are genuinely wanting to move the needle in this space, and making sure that they understand that it's not going to happen overnight, that we need to take our time, and it's going to take resources also to do this work. And so, you know, I'm Hispanic, proud Latina, working a lot with the Latino community, making sure that we have, I advocate a lot for having bilingual staff and not using an interpreter, that a lot can be lost in translation, you know, the quotes lost in translation, but it's true, right? Just, I always love to use the example of the straw in Spanish. You know, I'm originally from Ecuador. The way we say straw in Ecuador is completely different from another Latin American country. So it's very important that things don't get lost in translation. And so I'm here today to share what I've seen in our communities, because I love to be in the community, boots on the ground, talking to people, listening to them, acknowledging their concerns. And I don't want to lose their trust, because once you lose trust, it's hard to get it back. So that's it in a nutshell.
Thank you for those important points, Perla. We'll now turn to Silas.
Good morning. I am really honored to be here, and I've learned so much already just listening to the panelists. I'll be relatively brief. I am Silas Buchanan. I'm the CEO at the Institute for Health Equity, as well as ourhealthycommunity.com. We were founded as a social impact and social justice consulting firm, but we do very little consulting these days. We are now in an era where we really should be building things. And so we recently partnered with and received funding from Morehouse School of Medicine to build web-based platforms, ecosystems specifically designed to put and keep the leaders of faith and community-based organizations together all the time. I previously co-founded amechealth.org with the AME Church. I've since handed that off to them, but for those of you that know AME, you know that they are the largest mainline historically Black denomination in the world with, depending on who you believe, right? 2,000 congregations and 2 million members, or 7,000 congregations and 7 million members. But in any event, they're quite large, and amechealth.org became the official health information dissemination channel for the AME Church worldwide. It is now under their complete control. Very proud of the work that we did there. But Morehouse absolutely thought it would be a good idea to help me to begin to stand up and launch a couple of things. Ourhealthycommunity.com being one. Another brand, Our Health Ministry, is also part of the effort to ensure that we're working consistently to connect both leaders of faith and community-based organizations. We want to work secularly and non-secularly for the benefit of those organizations to shorten the distance between them, regardless of their geography, right? Series of best practices can begin to emerge if you're connecting organizations from one part of the country with organizations that are working at the community level on a similar or the same problem in another part of the country. Let's learn from each other. The experiences are very similar, and the impact could be exponential. We also work to shorten the distance between these trusted community-facing organizations and the community members that they serve. And also healthcare stakeholders, importantly, right? Healthcare payers, providers, government, academic, life science, and pharmaceutical stakeholders, many of the folks that are in the room today. Along the way, just for a little background, we received funding from NIH through NNLM, the Network for the National Library of Medicine, to better understand community leader and member trepidation around participating in clinical research. So we initiated what we branded the Research, Literacy, and Justice Project, RLJP, and drove focus groups. Let's hear from community leaders that have exponential reach to community members. All of these community-facing organizations have social media channels. So we drove focus groups in Atlanta, New Orleans, and Shreveport. A total of 34 community leaders participated. We were fortunate, in full disclosure, to have Merck provide some additional funding along the way. And we aim to better understand underserved community leader and member perceptions of clinical research. Not Tuskegee aside, inclusive of Tuskegee, but let's really get their feedback and input and insights on how they want to be communicated with, through what channels, the co-creation of materials with them, so we can hone in on what resonates. And you'll find that sometimes there are some geographic differences of the same materials that resonate. But in sum, we quickly learned that underserved community leaders and members still significantly feel as if they're guinea pigs. In our Slido, we just saw trust or lack thereof being a real significant and ongoing issue, and we heard that from the other panelists as well. It is very true. Significantly, distrust in the system and researchers continues to be a very real thing. Many of the folks that we spoke to were wondering where the researchers of color are, and how come their physicians who may be of color aren't talking to them about clinical research. So we're working on some of these things. What we heard also was many community members and leaders just got really used to taking medication. So when you look at things like cardiometabolic syndrome, hypertension, diabetes, they think back in their own family history. My grandmother took medication, my mom took medication, my uncles, my cousins, I do for blood pressure, we'll say. And so they see less value. Why should we participate in research? We just take a pill and keep on going. So those are some of the things that were bubbled up to the surface in our conversations with community. They worry about what happens to their data as well. What's it being used for? Who gets it? Why don't we get some of it back? However, importantly, they still see that participating in clinical research could have some value. And they had thoughts, real thoughts on the layout, design, graphics, color of recruitment materials. And they want to share them. They want to be part of the co-creation of them, but they will share them. So I'll stop there. Thank you.
Thank you to all our panelists for those opening remarks. We'll now jump into our discussion to close out the session, but as a reminder, we'll be taking questions using Slido. So we encourage audience members to submit questions using the QR code or by going to slido.com and entering the code DMI trials. So jumping into the discussion, I wanted to see an update of the word cloud that we put up earlier, just to get a sense of if there were additional insights or if we were still kind of staying within that trust realm as far as how the audience would define community engagement. Can we put that up really quickly? Okay, so it still seems like trust and collaboration seem to be sort of the biggest factors that people associate with community engagement. And when we started this body of work, one of the things that we wanted to make sure that we were pursuing in the way that we approached it is that we were really encouraging and finding insights that would help to encourage more meaningful engagement versus just one-off efforts or efforts that were not necessarily within the best interest of the communities that the clinical trials were aiming to serve. And so my first question to the panel members would be, what strategies have you learned in your own work that have helped to foster more meaningful community engagement, helping to build trust with communities that have traditionally been underrepresented within that realm? And so I'd like to start with Nadine.
Certainly, and thank you. And again, another great question. There's multiple methods, and I don't really like to use the word methods, honestly. It kind of feels almost so inhuman in and of itself, to be honest, when I hear methods of community engagement. So there's multiple ways in which I really believe that any of us can be most effective in engaging our communities. I mean, when I first move into any particular community or area, I want to know, the history of that community, what has been the history, particularly what has been the history in general, and then what has been the history as it relates to the systems, the health systems and research enterprises that exist in that area. That's key. Second, I really want to kind of learn, what is the culture? Where are people? What are people thinking? What space are people in terms of truly getting access to care? I focus on primarily increasing diverse representation in clinical trials and normalizing clinical research and trials. But I have to be honest that for me, in order to really do that effectively, we have to be very clear about what the systems look like in terms of access to healthcare. We can't talk about clinical trial participation and say, I want you to participate in a trial when people can't even get access to the system to get screened for cancer or any other health issue. So for me, it's very hard to kind of dissect them because the community doesn't say, oh, I'm not crazy about this institution, the research side, or this institution, oh no, I'm talking about the health system side. They say the institution and they see the whole thing as one. And so I think that's really important for all of us to really think about. The other thing is coming into a space of humility. I really am very clear that I do not know anything about most communities unless I learn from them and ask them. And I am not culturally competent in anything. I actually don't really like the term culturally competent because it implies you can now be competent and you've got the skills now to be able to manage a particular community. I'm a Black woman, and I by no means will say that I know the Black community and I can speak on behalf of the Black community. It's impossible. So I think that for all of us in terms of moving into an engagement space is to really and truly come from a spirit of humility and also a spirit of appreciation and respect for who our community members are as experts with incredible insight and wisdom, as I mentioned earlier. So that to me, that's like number one. If you're not even approaching it in that space, we've already got a problem because it will show up in your actions and the words that you use. So that's one. Two, I think, and I'm just going to touch onto the words that you use really quickly on that. And that is because, when I look at and think about research, one of the things that really seems to me that something we all can change, regardless of whether the FDA or anyone else makes it policy, but the terms that we use, such as subjects, calling people subjects is so highly, it just speaks to that lack of humility, right? We're talking about people who without them, we can't advance anything, any healthcare, any health outcomes. We cannot. So they're partners, they're collaborators, they're volunteers. But even as a volunteer, so they're a volunteer who's bringing expertise and sharing their time to work together as a partner to move forward in advancing access to care. So again, when I speak about that humility, it's kind of all of those things. It's the words that we use, the perceptions that we have, and the importance of recognizing our communities and our patients as experts in their own right and being able to really build on that. So the methods then that I use in that is really, again, it's not even a method. I feel like it's more of a spirit of humility than it is a method, that because it almost scientific makes engagement a science. And it is a science. There's science to it in terms of methodologies, but there's also a spirit that you have to show up with a community. And that those are two things that need to come together to be effective. So you can science all day, but if we don't have the right spirit and attitude and heart and all of those things, then all you will do is science. And what you get in, hard science, is what you're going to get in response from the community, a hard wall. So I think it's really important for us to kind of move into this space of operating truly from a space of humility. And then the methods that we use in partnership and develop in partnership with the community are the things that then I find for my research and for my work has always been most effective, being open, trustworthy, and all of those factors. But then also really starting to make this idea of clinical trials, this big abstract thing that we think about from a community standpoint is this big white sterile room with a lot of steel and metal, and someone in a white coat with ready to give somebody an injection. Like when someone hears a clinical trial, that's typically kind of the picture that people get. And just as my awesome colleague Bridget just mentioned, really moving to normalizing that also if you're taking aspirin, if you're taking any kind of medication, you actually are already a beneficiary of a clinical trial. So when you go and fill up any prescription at that drugstore and you take it, once it has to come through the drug system to CVS pharmacy or wherever, really normalizing that conversation. And that to me is a key piece. And then from there, engaging with our community. So I hope I answered the question, but to me, I always have to say before we even keep trying to level set into methods, we've got to understand the heart and the spirit of academia and how it is totally counter to how we engage with our communities. And so we have to really recognize it's the science and the heart that need to come together to really move this work forward.
Such a great point. And so much of what I heard within those remarks, Nadine, were just the importance of partnership and collaboration and really looking at the community as experts in their own right, instead of as, coming in as like sort of the saviors that academics typically come into and feeling like we have all the answers. And so I'd love to hear, Bridget, I know that you've done a lot of work with trying to engage communities through other efforts, like by partnering with people within industries like fashion and other non-traditional clinical trial industries to help get people more engaged. I'd love to hear how those experiences have kind of helped to shape a little bit more engagement with the groups that you've worked with.
Yeah, I'm absolutely happy to do that. I do want to just say this one point, and I think it's really important because without it, I would not have been able to have anyone with Louis Vuitton, Estee Lauder, La Mer, Tom Ford, or Joe Malone, or Hauser and Wirth, which is the second, Ivan Wirth, the second largest art dealer in the world. Had I not had this understanding when I made the decision that I wanted to do this, it's my own health experience. It's what has driven me to continue to do the things that I do in this space. So I come in with my heart and my soul absolutely open. And I do so because I'm a survivor of colorectal cancer. When I was in I was a few months before I was starting graduate school in 2002, I was diagnosed with colon cancer. That was initially, it was not a misdiagnosis at all. They thought it was something related to my reproductive organs because that's where they saw tumors. But as the weeks and the months went on, and I had one procedure to find out what was going on. That was June 15th of 2002. And by September of 2002, they learned that it was colon cancer and there was cancer in other parts of my body. I had a total of 8 specialists at the University of Chicago. Each one of them kept telling me, you're going to be fine. I've done this surgery a number of times. You're going to be fine. One of the people who was the most outstanding was Dr. David Cohen, who's a reproductive endocrinologist, who said to me that I want to maintain the integrity of your reproductive system because you may 10 years from now decide you want to have a child. Me experiencing this thought, I don't know what he's talking about because I am going to die because it's everywhere. And I never had an experience with anyone in my family who had gotten diagnosis of cancer and lived to do anything. All of them were dead within 2 years. That wasn't the case for me. So when I finished that entire journey of having cancer in my reproductive organs, my colon and other parts of my GI system, and having a lot of things removed and a lot of things reconstructed and left out of there, continued on. I was still a graduate student, moved to Paris, began working at the Musée d'Orsay to do my research for my dissertation. And then a few years after that, had a baby at in 2006. Not that I was planning to have a baby, because I just assumed those doctors were just saying that so I could feel okay. And I had a child who's now 17 years old at the University of Chicago's lab school studying to become a neurobiologist. So why I point this out, I point this out to Black women and anyone that I am trying to bring into Akira, to let them know that I've had these same experiences with these healthcare, with these doctors, with these surgeons. Although my doctors and surgeons, God bless them, because they were like a champion for me. All of them were. They consisted of white men, Asian women, Black women, and Black men. So I had a really nice rainbow coalition of healthcare professionals that were all beating a drum and saying, we're going to keep you alive. We're going to keep you alive, even though I didn't believe it. I think that's important to do that, because if you walk into any community as if you're doing them a favor, I'm here to save you. I'm here to educate you. I'm here to tell you what you need to do. So then I can be able to look like the hero, that I can be able to be the savior. I can be able to go back into my actual world and tell them, look what I've done for that group of people. I don't see this work like this at all. And again, I'll go back to the art world, because at least the folks that I worked with when I was at the Art Institute of Chicago, the Metropolitan Museum of Art in New York City, the Louvre, the Musée d'Orsay, you are working collaboratively with everybody. There is no such thing as this lone wolf that only exists in Clint Eastwood movies when he was a cowboy, when I was a little girl growing up and watching him ride into a town, shoot it up, do his thing, and then within 90 minutes, leaving it and saving a day. And no one has any real engagement with him. They don't know who he is. I can't even tell you the character's name. That's not the world in which I function in. That's not the world in which nothing like that functions in real life, not effectively. So when I thought about who would I partner with to help to even legitimize Akira, it was like a no-brainer. Of course, I'm going to go to Louis Vuitton and bring them in as a partner, because they already have a relationship with the Black community. Black people buy Louis Vuitton. Black people, rappers and hip hop artists, sing the praises of Louis Vuitton and Gucci for 3 minutes and 27 seconds. They give them a commercial. Why do they do that? Because Louis Vuitton supports midnight basketball during the holiday season. Because Louis Vuitton will have any Black person, whether they're Jay-Z or the guy that lives on my corner, that comes into their store, that when you walk into their store, they're handing you champagne, they're rolling out a red carpet, they're feeding you. Even if you walk out of there and never buy anything, they know how important it is for you to feel like you're welcome, like they see you, like they care about you, like they hear you, like they see you more than just a customer or somebody who's about to consume their product and they're about to make a huge amount of profit on you. They see you as a human. They see you as a person. They connect with you. They do this all the time. And in my opinion, they do it better than anybody else. This is why people do everything they can to buy those clothes. So I thought, bring them in. So not to use Louis Vuitton as some mechanism to get the Black community to say, yeah, I want to participate. Yeah, I'll participate in a clinical trial. You're about to give me a Louis Vuitton bag. It's not even about that. I just want to get Black women to a point where they would at least consider it. That's all, just to get them to consider, to understand the various phases of clinical trials, why it's important to be in clinical trials. Why is it important to even think about this? What impact is that going to have? So it's far more, so this is where this notion, and I've seen this in some cases because I've had people in the industry to reach out to me over the last couple of years, and they think, you know, and they'll ask like, how many Black women do you have as members of Akira? You know, we have tens of thousands of Black women across the United States, but all they think is like, okay, then we can just scoop them all up, put them in the clinical trials, and now we've satisfied our diversity need. This is not about that. This is a long-standing, long-term relationship. It's just like if you have a husband and you want to have a relationship with him beyond the honeymoon, you are going to have to know that I am in this for the long haul.
Yeah, thank you so much, Bridget. Those are such great points about really making sure that it's not just about one-sided needs or the needs of the clinical trial sponsor, but really getting a sense of the needs of the community as well. So I wanted to quickly take a question from the audience and turn to Silas. And the question is, what are the panel's thoughts on how participation in clinical trial research is compensated? For background, the ethics boards tend to lean towards limiting compensation for fear of undue influence.
So I think that's a good question. If we're talking about equity, right, an equitable partnership, you know, community members are not unintelligent about the system. They are approached consistently. I happen to live in Cleveland, right? And so whoever has the NIH grant of the moment, it could be Cleveland Clinic, University Hospital, Metro Health, Cleveland State, Case West, right? They're knocking on the community's door. And with FDI guidance, it's only going to get worse for community, and community recognizes that. When community turns to researchers and may ask about compensation, by the way, we paid $50 an hour for folks that participated in the Research Literacy and Justice Project. Many times researchers are just offering to buy them lunch, right? We'll give you a ham sandwich for all that brilliance that's in your brain, right? It's the most ridiculous thing. So, and then when you look to academic institutions and you take not even a hard look at what the indirect costs are that are associated with anything that an academic institution does, it could be 50% of the dollars that are made available. So the inequities are systemic, and it's not, the community should not be outside the door looked at, and I think Bridget kind of touched on this a little bit, looked at as, and so did Nadine, looked at as folks who are to be leveraged or used or are chattel or just are, we'll just run through you and we're just going to put it out there. And if we don't get you, see you later. We're going to go to somebody else and we hope to get it at no cost. So I think that the system in and of itself is inequitable. There needs to be some changes. We're having some conversations, you know, our team with both Case Western Reserve University and University of Maryland to create training for community that may want to partner more equitably with researchers, and researchers also that want to partner more equitably with community. And what we're building is this middleware piece. We are not payer, provider, government, academic, life science, right, or researcher. We're also not community. However, I'm sitting with you guys here today, and this afternoon, I'm going to be on East 75th in Woodland. Not that you know where that is in Cleveland, but it's the hood, okay, in a church basement, talking with a group of pastors this afternoon. So it's just important that we have systems that we're building that are independent of healthcare stakeholders, sit on the side of community, and perhaps we will be in a position, oh, and I don't want to use the term negotiate, but to leverage more equitable compensation for community members and funnel those dollars, because I'm not under any restriction, right? I can do whatever I would like with my money, and I can give it to them if I choose to. So this is what we hope to build. Let's educate community. And while we're raising literacy, last thing, while we're raising literacy on the community side, and I forget, maybe it was Nadine who talked about this earlier, let's raise cultural competency, let's raise cultural humility, let's raise cultural intelligence on the other side. The onus is not always on the community to get smarter. It's also on the researcher side to be more culturally intelligent.
Those are such great points, Silas. And this is a really important question. So I'd actually love to get both Andrea and Perla's perspectives on this too, starting with Andrea.
Great, thanks so much, Sandra. So I do want to emphasize a couple of points and lift up a couple of points that have already been mentioned. So, number one, because we need to treat community engagement not for the sole purpose of research and really think holistically, I think it's also important to raising actually Dr. Barrett's earlier point of community experts. So who do we define as an expert? And what we see in industry is experts that are deemed or experts with degrees, right? So folks from academia, folks with private sector expertise are paid very well to provide their expertise to clinical design, to implementation, evaluation. And so I also think part of this question depends on what we're asking for the community member to do, especially if we're asking community partners to provide their expertise on how to engage specific populations, how to communicate to specific populations. I do think then, we do need to be having this hard conversation of, are we segmenting expertise based on whether they are a community expert or defined as a community expert versus defined as an academic expert. So I think there should be some conversations around that to really make compensation equitable across that expertise, because whether a community partner is providing the expertise, that value is the same, or if not, I would argue more when it comes to community engagement than the expertise that I may be providing from the academic space. And so I do think some about this too, the question earlier too, Sandra, of what has worked. I think that one really has to be providing a space for bidirectional dialogue and conversation, and that also includes compensating the community-based organizations as well. So I think, within this broader compensation question, I do think that one has to be looking at this from multi-levels. So looking at the actual individual who may be participating in the trial itself, what they're contributing to the trial, and then the system around that person. So whether it's the community organizations, the churches, the other community leaders, one really has to be viewing this in a different way. And that's where I would push the enterprise to be able to start thinking through how to create a more equitable payment system.
Thank you, Andrea.
Yeah, love this. So, I think Dr. Barrett has said this before, one of the times that she spoke, like community engagement is a special skill set. It's not something that everyone can do or everyone understands, right? And so I think there's a lot of things that go into place, for example, humility, empathy, respect for cultures, for the food, for the music, for the way our dialects, all that is so important. And I love what you said, Andrea, about not just going into communities and expect to get all that expertise and all that they have to share with us and just take their information and run with it. Like, they should be partners in this, right? We should be inviting them to help us when we're talking about the protocol and the inclusion exclusion criteria, like getting them involved from the very beginning. Because when you go into communities and you try to tell them this is what we want to do, we need to listen to them when they say it's not going to work in our community. Let's talk about this, right? Let's have that bi-directional conversation about what will work and won't work. And let's talk about this, right? Let's not come into communities and dictate what is going to work or not work for them. Let's talk about where the sites are going to be, right? If the site is an hour away and there's no public transportation, no people don't drive or don't have a car, that's not going to work, right? Let's look at sites that are closer to where the communities live. So I think there's a lot of conversation that needs to happen when these studies are being developed, and really listening. And I can't say this enough, listening and acknowledging what the communities have to say, and realizing that one of the things that I'm very big about is making sure that the communities understand like what their rights are as a research participant, and giving them the option to decide whether to participate or not. Like Bridget mentioned, don't think that because I have a database of 1,000 plus people in my data that everybody's going to jump and want to participate right away, right? Let's give people the option. Let's give them the information they need to make that decision to participate or not. So, yeah.
Can I add one thing to this?
Mm-hmm.
Because it's just all so well stated, but it's understanding culture. And I don't want to make it sound as if it's going to be impossible, or it's going to be very difficult without equitable partnership at the community level, is what I think we are all saying. And just because you are, of the community doesn't mean that you're from the community, as someone once stated. So you've got to understand the culture, and faith-based organizations have their own culture. And if you don't understand that, you're not going to get anywhere. If you walk into a barber shop or a beauty salon, there's a culture that goes along with that, right? And you've got to understand that culture. And so you can be as empathetic as you'd like to be, but unless and until you are engaging those experts who understand the culture, you're not, honestly, if we're speaking honestly to this audience who's listening to us, you're not going to get very far. So you've got to make sure that you're engaging in a sustainable sort of way. We may not have time to talk about sustainability, but where you are continuing your effort to understand the culture and how to engage.
I just want to make one final point on that remark. So in all local communities, there's existing infrastructure, whether that's coalitions or groups of people that understand the culture. And so part of what we're saying too is, one doesn't have to recreate this. It's about identifying those groups that are already in the communities. So, in the case of North Carolina, there's Latin 19, there's ACT Plus, there's many coalitions of partners that have been having these hard conversations, not just around clinical trials, but how does one improve overall health outcomes for different marginalized communities? And I think that that's where there needs to be a shift in the framing of, this is not just for the sake of research, but this is about improving population health outcomes, and improving population health outcomes, particularly for those that have been systemically excluded and marginalized through not just healthcare, but through various systems of power, in the U.S. and outside of the U.S. And so I think it's important to understand that and to partner with those groups to better understand the culture, and also I think a point that we're saying here too, not one there's no one person that's going to be able to represent a community or that will understand every aspect of a community's culture. And so part of this is also, partnering with many people, and including team members on one's internally within an organization, and then also externally as well.
Thank you, Andrea. So we're technically over our discussion time, but there's one question that I really wanted to get to. And so I want to do a quick round robin with our panel just to get their insights on this. And so how do we measure success in community engagement efforts? And so we'll start with Nadine.
Because I'm Barrett, with the B. So no, I thank you, Sandra. I think that it's really critical, to really think about what metrics look like, not just in terms of how we think about metrics as academic institutions and organizations, but really what does success look like to our communities and to our patients who are participating and engaging in our clinical research and trials? What does effective community engagement look like? And I know there's a lot of studies that have been done. Consuelo Wilkins and many others have done quite an amount of work in this space and kind of just defining what that looks like, what these metrics look like. But I think that it's also important to kind of think about it from the community standpoint, is what are the things that were important to them? What were the things that makes a meaningful collaboration and a partnership? What are the things that, how was the communication? What was the partnership? Was it really trusting? Was it really, and what does trust and trustworthiness actually look like? We still haven't really got measures around what that truly is as a country yet, in terms of health systems. So I think those are really important. More granularly, I mean, just simply asking some of those questions from a qualitative standpoint, evaluation standpoint of metrics is really important. And also thinking about what is the ultimate impact. So for me, in what way? There's a great study that was done by Kimberly Johnston. I had the pleasure of being the engagement leader of that. It was funded by PCORI. And this is just to give a tangible example of, we actually were able to look at, based on our community experts' insights throughout, from the development of the idea all the way through to the funding of a comparative effectiveness clinical trial through PCORI. Our community experts were fully immersed and a part of that. What was really powerful about it is that we can actually see, and the partners were able to see, how they literally change aspects of the study design, like critical aspects of the study design, based on their input and their insights throughout the partnership and the collaboration. So those types of metrics, if you can't look at your study and be able to say, oh, it shouldn't be that on the front end, oh, we got all this feedback and input from the community, and that's why we should do this. And then you kind of do your thing, and then you come back on the back end with your results, then it's not really engagement at all. But if you can do that at the front end, and then let that shape your question, shape your design with your partners in tandem together, and then you get to that point where you can truly see this part of the study design and our protocol, we literally shifted it based on the insights that we got from our community. That based on the findings, the community interpreted it this way, where we were interpreting it this way. So we shift that to incorporate that understanding from the institutional standpoint and from the community standpoint of what these findings mean, and therefore what the next step is for us in terms of implementation and action. So I know that was a quick round robin, but that's just to give an example of what metrics should look like. You should be able to see a clear shift of what this added expertise brought to the work to move it forward to advancing equity.
Thank you, Dr. Barrett. So really quickly, we'll turn to Bridget.
Well, I want to start with the end in mind to answer your question, because I'm not a social scientist. I'm a lawyer and a bioethicist, but at heart, I am I'm a humanist over in the humanities. So I want to think about the end. It's 10 years from now, and every single clinical trial has, at a minimum, of 12.5% of Black community. That's Black men and Black women that are participating in every single clinical trial. How do we accomplish that? So I'm just going to start at the end and just do reverse engineering and go back. How is that possible? Because the local urban farmers are participating in it, because they're connected in this large apparatus, this new apparatus of clinical research. The artists, the singers, the rappers, because of the Black and Brown music and hip hop associations and groups that are already embedded in the Black community. So we've been able to bring those people in. They're all sitting on this table. They're a part of that roundtable discussion on how did we design the clinical trials? What was my input in that clinical trial? There are also the women's organizations, the mother boards, the parents, the members of the parent association of the local schools, both private, Catholic, public, they're all a part of this as well. Not to mention the healthcare groups that are already serving and in the Black and Brown communities, like Haluna Health, all of these various groups of people that make up that community, as well as the art museums and the galleries and the local galleries. There are people from each one of those groups that are sitting at that table that helped to design that clinical trial that ultimately brought us 10 years down the road to 12.5% of Black participation in clinical trials. So that's where I think or can see us getting to.
Thank you, Bridget. So we'll quickly turn to Silas and then Perla.
Yeah, so real quick, you can't measure, right, what you haven't defined. So success looks different for everybody, right? What does success look like for community members? I don't know, we could talk about it. What does success look like for community-facing organizations? We can talk about what does success look like for researchers? They're different for everybody, so they've got to be defined and focused on. But if I'm answering the question in 30 seconds, I would say the number of community-facing organizations, faith and non-faith, that have been trained on how to equitably participate with researchers that are already knocking on their door, and in droves will soon be knocking on their door even in even greater numbers. How are they prepared to equitably participate? Do they know how to do it? Do they understand, well, what their rights are and how they should be compensated, and the impact that what they can provide will have? And if we could measure that, if I could measure that, at least city by city, that we stepped in and trained 100 community organizations in each city to better understand. And then on the other side of that coin, we also trained, or at least engaged and informed researchers to raise their cultural competency. Also in those communities, I would measure success that way.
Thank you, Silas. And I never lose hope. And everything that you've said, and Bridget and Dr. Barrett, I pray all the time that we will see that in my lifetime, some sort of that. I would love to see some sort of sustainable community engagement where people are talking about it with their family members, with their neighbors, co-workers, about the importance of clinical research. So like I said, I never lose hope, and that is my hope.
Thank you, Perla, and thank you so much to all of our panelists for that excellent discussion. We'll now be taking a break for 10 minutes and we'll reconvene at 11:45. For our next session, Building and Scaling Innovative Clinical Trial Infrastructure, my colleague Trevin Locke will return as the moderator.
All right, welcome back from break, everyone. I'm excited to be back to moderate our second session. As I mentioned in the intro, I'm Trevin Locke, Assistant Research Director here at Duke-Margolis, and I'll be moderating our session on innovative clinical trial infrastructure. While I introduce today's panelists, we do have another question for you all up in the Slido. So if you could please go and answer that. We'll come back to the results in a bit. But for now, if I can have the list of panelists, I'll introduce a great set of folks for today. We have Pamela Tenier from the Chief Scientific Officer of Medable, Megan McKenzie, who works on patient inclusion and health equity in the Chief Diversity Office at Genentech, Amanda Wagner-Gee, Associate Director of Faster Cures at the Milken Institute, Martin Mendoza, Director of Health Equity for the All of Us Research Program, and Grail Sipes, Assistant Director for Biomedical Regulatory Policy at the Health Outcomes Division of the White House Office of Science and Technology Policy. And while you're all answering our Slido question, I'm going to hand it to our panelists for some brief opening remarks. And then much like the last session, we'll get into moderated discussion and audience Q&A. So after you answer the poll, you can start asking us questions as well. So I'll invite the panelists to all come on screen. And Pam, we'll go to you first.
Thank you, Trevin, and I'd like to thank Margolis Center for Institute for Health Policy to invite me to this very important discussion. I think as we heard this morning from the panel, if we don't include diverse populations, we get to knowledge gaps in our understanding about a medical product, and that is not what anybody wants. So we need to do better. And at Medable, we're a decentralized clinical trial platform, and our mission is to make clinical trials available to everyone. And personally, I'm focused on evidence and removing obstacles for using technology in clinical trials so we can have responsible adoption of those methods. And then with my city hat, I used to be at City, I still also really dearly participate and organize collaborative efforts to address some of these issues. So historically, I think we can all agree, and also heard this morning, that in addition to all the issues of trust and engagements, we've also made trials really, really hard for people to participate in, both as a participant and as a site. And one of the things we need to do is have protocols that work for more people, for sites and participants. And we know that we can do this because the recovery trial in the UK was able to enlist sites that had never done clinical trials before and reach people, far away from the academic centers to participate in trials. And they had almost 55,000 participants in the recovery trial that really brought us a lot of information about what to do with COVID. And the other thing that I also want to mention is that I think people have the best intention when we start thinking about who we should enroll in clinical trials. And many groups want to enroll more diverse populations, but we all kind of become victim to the first patient, first visit situation where then all of a sudden things have to go fast. And we kind of just enroll whoever we can without thinking about setting up the right systems, as we talked about earlier, to make sure we enroll the right people. And from that work at City in the past, we started a project around that. There were some recommendations launched in the last year that people might want to take a look at that sort of summarize a lot of the things that were said this morning. But when we think about clinical trial infrastructure and scalable solution, naturally, I would bring technology as a way to reach more people, as an underpinning to connect humans so that we can address this. And if we can do this right, we can then also scale it and bring it to more people. And then if we do this right, we can address issues of geography and hurdles, like, do we need to take a bus to go to a visit, or can we do it on a phone, or can we do it via a Zoom visit, so to speak? But then if we think about using technology, we want to make sure we don't create an additional hurdle of the digital divide, which is real, and it's not monolithic, right? Not everybody has no access to data plans or things like that, but there are places in the country where broadband just isn't as widely available. So it would be another hindrance for those people if we were to use technology for them to participate in these trials. And we just need to make sure that we keep that in mind. And then if we use technology to reach more people, we also make sure that we take into consideration that we cover data plans if data has to be submitted, that we make sure they have the tools that they need to do it. If they have a flip phone, like my dad would have had a flip phone, he couldn't participate in a clinical trial. He didn't have a smartphone, so we need to do BYOD, but then also provision devices in case the requirements aren't met by the device, the phone or the tablet that the participant may have. And I think we just need to simply make what I really liked about this morning is the concept of coming in with the spirit of humility, appreciation, and respect. When we devise all these solutions, we just need to make sure that those solutions actually perform in the way that we think they're going to perform, and that we talk to the populations that would be using those solutions. And that's not typically a Silicon Valley approach to sort of come in with humility, but I think it's something that we need to think about. And we do need to have lots of conversations and communication about those solutions to make sure that they work in the intended purpose. One of the things we're also doing is we're supporting the Tufts Center for Study of Drug Development in an activity they call PACT Consortium, where they're collecting data about the use of decentralized methods, sort of the type of trials, what phase they're in, what population, what medical product, the modules they deploy, and then sort of protocol performance, like are they reaching the populations better and than they would have without those things. And we're getting some preliminary data readouts, and they're being analyzed. But it does look like we'll have more information about whether those technologies actually do what we think they're going to do, and that we will be able to deploy them in a fit-for-purpose way to sort of help achieve the goal of reaching underserved population and underrepresented populations. And with that, I'll turn it over to my next panelist. Thank you.
Thanks so much, Pam. Definitely look forward to seeing more from that work as it comes out. Next, we're going to go to Megan.
Thank you, everybody who's in the audience today for really being inclusion champions. I'm Megan McKenzie. I work at Genentech in San Francisco in the Chief Diversity Office in Patient Inclusion and Health Equity. And I have the honor of doing inclusive research full time. It's very humbling. I've learned a lot about diversity and inclusion, and we believe D&I is everybody's business. And that means in our steering committees, in our advisory committees, in our patient committees, supplier diversity, sites and our site alliance. And I heard a lot about cultural humility and really learning from sites who have trust in their communities and how we can be better at building trust through pharma and biotech. And some of the things I hope to touch on during the course of the hour is how we have to think globally also. I think we've been better and need to do more in the US on reaching Black and Latino and other underrepresented groups like LGBTQ groups. I think we're making some progress. So there's a lot of hope, and I love that everybody's talking about it, and all vendors are coming out to try to help with that. Some of that is around AI. Pamela, I love you talked about, I mean, that is the future, how we're understanding disease better through AI, hand in hand with bench scientists, but also how we're interrogating our entry criteria and protocols better, both with our sites and through real world data, and understanding who we're leaving behind if we remain truly conservative and where it's safe to loosen that criteria to make sure we're getting in real world populations. And I hope to talk a little bit about decentralized trials. We have a successful trial called Katori. It's fully decentralized, reaching Native American, Indigenous, and Alaska Native very successfully. So there's a little bit about the website and connection in. We have brick and mortar as well. And we've consulted with Native American Indigenous communities, and our PIs identify as Native American Indigenous. Again, everywhere you are bringing in representation. So hope to talk a little bit about that. And the other is hybrid trials. I know we want to go fully decentralized, but I do feel during COVID, it really forced us to think more about home nursing, local labs. We have one site in ophthalmology. They're truly extraordinary in Virginia, Wagner Kapoor. They created Site Forever, and they have a van where they take ophthalmology equipment out to nursing homes, and they don't just diagnose, they treat. So more remote ways to reach our patients, both in clinic and clinical trials. So hopefully we'll get a chance to talk a little bit about that. And I'll be remiss if I didn't say something about biosample diversity, the way we partner with each other, other CROs, other pharma, to improve diversity of biosamples, and of course with folks like Martin Mendoza and IAH, all of us, increasing diversity of biosamples are extremely important. We have gaps in our data. We're going to be, populations will still be missing from our research. And Martin, I know I'm going to hand it off to you, but I have to tell you, I committed, I'm a melanoma twice survivor. I committed to joining all of us, and I did it 2 weeks ago. It was so easy. You made the consent so easy to do. It was both video and words. I actually like the words, that's my thing, but it was great you had both. Made it so simple to sign up. So that's just my pitch for folks, you can get free DNA testing, you could be a part of the future with research, and folks like Martin and NIH are making it really, really easy. There's a lot to learn from him. And just thank you again for for having me here. I look forward to hearing what everybody has to say.
Thanks so much, Megan. Amanda, we'll go to you next.
Great, thank you. And thank you, everybody. I'm really excited to be here on this panel. So I loved hearing everybody's ideas and sort of talking about this. And first session, I really resonated with me. It's the idea of sort of embedding our community colleagues more equitably in the enterprise. So we're really pulling through that idea of sustainability. And I was also really struck by the idea of durable two-way bridge building, that bridges don't go only one way, so that we're sharing learnings back and forth between community and the enterprise. So I've been thinking a lot about sort of how we can sustain those relationships and also build or any existing or nascent infrastructure so that we're thinking more, yes, decentralized trials for sure, but also opening up sites that are closer and easier for people to get to when they do need to be at a physical site. And so how can we build that capacity, expand capabilities to extend reach and access? I think that gives us a lot of opportunities to, first and foremost, drive toward research that's improving health outcomes for everybody. I think it also gives us an opportunity to think about what a warm base of research looks like, so that it's there and existing when we need it in times of emergency, like we did during the pandemic. And I love Esther Akrofa as the leader of the health programs at the Milken Institute, and her favorite way to say this is, how do we move from islands of pilots and scaling, as Trevin said in his opening remarks, to connecting an ecosystem of excellence and really sharing the learning. So I'm taking a broad view of infrastructure here. So it's sort of the traditional things that you would think of, but also non-traditional sites, retail, community serving organizations, workforce, community hospitals. So we've spoken with a lot of different people around the enterprise in those places, community sites, community organizations, health systems, government, companies of all shapes and sizes over the past few years, just to learn more about what do we need to help support this infrastructure closer to communities. And we, of course, have learned a ton. I know we're going to get later into talking about more on sort of the challenges and opportunities for that. And so I'll try to preview a couple without taking up too much time now. But one that we heard across the board and that a few other panelists have alluded to earlier in the session was that there's limited opportunity to just connect and share across those sectors. And that really sort of ways to spread that learning. You can do that if there's a place for everybody to connect. So we're trying to address that with one of our efforts at Faster Cures. We just launched it, called Enrich CT. It's something we're still building out. We're really excited about it. I was seeing a forum that's building connection and informally sharing best practices for this kind of work. Other common challenges to tee up here, and then we can talk about it later, are around regulatory burden in terms of site certification, recertification, IRB. Other people have talked to that. A lot of technical aspects of joining and maintaining and managing systems, workforce development and retention. How do we sort of make clinical trials something that people enjoy participating and want to come back to, so you don't have to recreate that part of the infrastructure over and over. Mentorship, and then sort of stable investment and predictable research. So I'll stop there and pass off to the next person. Thank you.
Thanks so much, Amanda. Martin, we'll go to you.
Thanks, Trevin, and thanks to Megan for that awesome lead-in, that awesome plug. That was tremendous. So hi everyone, I'm Martin Mendoza, and I'm Director of Health Equity for the All of Us research program at NIH. So for anyone not familiar with what All of Us is, so All of Us is an effort to bring together at least 1 million volunteers, the reflected diversity of the United States, who will volunteer the health data for decades to come. So the program is open to people both healthy and sick from all communities. And so unlike a single research study that is focused on a specific disease or population, All of Us is really meant to serve as this national research resource to inform thousands of studies covering a wide variety of health conditions. Importantly, when you contribute to all of us, it makes it possible for your community to be represented in medical research, and that's really why we're all here, right? All of us, as you know, is led by NIH, and it is actually the cornerstone of the Precision Medicine Initiative that was launched in 2016 by then President Obama, with a goal of moving forward the promises of precision medicine. Now, importantly, all of us is not a clinical trial. As I mentioned earlier, we are clinical research, however, but sort of the best practices we have developed, we think are very applicable to clinical trials. So, for example, when we look at the enrollment of the folks, of the 550,000 folks or so that we have enrolled, about 50% or more, closer to 46%, have been self-identify as a racial or ethnic minority, which is, obviously that's a huge percentage. And then when we think about diversity in sort of broader terms, when we think of sexual gender minorities, rural populations, those with disabilities, folks with lower incomes, lower access to healthcare, lower educational levels, when we include all those folks, and we look at diversity as that sort of larger metric, about 87% of our 560K participants fall into one or more of those categories. And so when we relate that back to the purpose of this meeting, or rather this session, and we think about infrastructure, what are some of the infrastructure-like things that we have done to achieve those numbers? It really goes back to this concept that everybody here has heard of, which is called meeting people where they are, right? And so to do that, we've done things like partnering with large healthcare provider organizations, including federally qualified health centers. Obviously, we have an online option that Megan took advantage of, and we also have mobile traveling buses that travel the country, talking to people about all of us, and with the option to join on the spot if they wish. So I'm happy to get into more of these as our session goes on. But thanks again to Trevin and Asim for having me here. Again, to Megan for the awesome lead-in, and I'm looking forward to the discussion. Back to you, Trevin.
Thanks, Martin. And Grell, we'll go to you.
Thanks so much, Trevin. Can everybody hear me?
Yes.
Okay, terrific. I had a few audio issues dialing in. Thank you so much for having me here today. I'm delighted to be part of this discussion. I'm an assistant director in the Health Outcomes Division at the Office of Science and Technology Policy in the White House. The Office of Science and Technology Policy exists to sort of provide advice on science and technology to the president, and the director of our office, Dr. Arti Prabhakar, is the top science advisor to the president. And there's an enormous focus in this administration on improving health outcomes. So I'm in the Health Outcomes Division. As everyone knows, we're in a situation in this country where we spend a lot of money on basic research and on healthcare, but our outcomes are no good relative to other countries, and that's particularly true for underserved and minoritized populations. So my portfolio sort of extends to all things related to clinical trials, equity in research, and evidence generation generally, sort of more efficient evidence generation. So I'm really looking forward to the discussion. I would just highlight a few things up front. Like, I think that some of the goals of this session that Trevin and others have flagged are, number one, as we move towards hopefully a more modern infrastructure for clinical research with more point of care trials, more decentralized trials, how do we make sure that our representation is equitable? And we've been talking about that a lot today. That's really, really important. And also, as we try to launch more pragmatic and kind of distributed trials, like Pam was mentioning, the great success that the UK had with the recovery trial, as we try to do that more in our very large and complicated country, how do we do that across the different networks and groups of sites that we want to be represented? As Trevin pointed out at the top, it's quite fragmented right now. So A lot of the work that I've been doing over the past couple of years has to do with thinking about public-private partnerships and how different sectors, the government, excuse me, private sector and nonprofits can kind of help each other to move this forward as we think about where the resources are going to come from and how to change things, as Nadine was saying at the top when we got started. You know, how do we change things at a systems level, and how do we join these efforts together? And so there are just a few things that I would highlight. You know, obviously, when we talk about the infrastructure, we're talking about all the people and places who currently participate in research, plus all the ones that we need to bring in, right? We need to build our infrastructure, particularly in rural and underserved communities. So you've got, you know, pharma, which is a tremendous driver of research, you know, sites that are accustomed to working with CROs. We've got sites that are accustomed to getting government funding. We've got those networks, NIH, NIAID, et cetera. You know, the academic medical centers that also, you know, support a lot of that. And then we've got all kinds of new players that are trying to come in and have a lot to add. You know, the FQHCs, retail sites, pharmacies, all of these different locations. And so a lot of what I have thought about and worked on is what is the right way to sequence efforts to help these different sectors and these different networks to work together and kind of leverage each other. And a lot of people are already thinking about this, including all of the folks on this call. So I think we're at a point where we can really make some progress. And I'm very optimistic about that, if only because the current situation is a problem for almost everyone, whether you're a commercial sponsor, you're in an academic medical center, or you're in a community that's being left out of research. Everybody's having a problem with the way things are working right now, and solutions, I think, are starting to come up. So just to highlight a couple of things, and a few folks have already mentioned this, a huge piece of this is how to use data more efficiently. You know, how to try to use our electronic health records more efficiently, not gather data multiple times for the same patient for different purposes, and things like that. You know, and that's a highly technical area, but one that is really, really important that I've done a lot of work on. Finally, I'd just like to say one word about investment to flag something that I think we'll talk about further. This is just one example, but in thinking about the role of government in driving investment in this space, and bringing more resources in, you know, this administration has also stood up ARPA-H, the Advanced Research Projects Agency for Health. And I was very fortunate to be able to work with them as they developed an important initiative that they're currently launching about advancing clinical trial readiness. And what they've got, which is quite ambitious, but I think very important, is they're setting up a network of people and places, ARPA-Net-H, which is going to serve as kind of a test bed and a home for developing innovation in a lot of areas related to health, but including to clinical trials. And this is going to be their first initiative within that sort of 50-state hub and spoke network that they're currently recruiting people into. And they have a very strong focus on equity, trying to enroll more diverse populations, try to use the data more efficiently, and they're looking to fund innovative approaches to that. So ARPA-H is going to fund things that are higher risk, higher reward, but I think that their entry into this space is a way to encourage more investment and more partnership, demonstrate different ways of doing things, and bring in other types of investment, both from the government and from the private sector and from nonprofits, that, you know, maybe operate at a different risk level, but need to come in order to sort of fund a broader infrastructure. And so that's it for now. Aside from, I just wanted to call out Bridget's amazing story earlier. It's just incredibly, incredibly powerful. I just want to thank her for sharing that. Thanks so much.
Thanks, Carol, and thanks to all of you for a great opening here. I think we have a lot to potentially cover, and about 40 or so minutes to do it in, so we'll see how far we can get. So first, I want to put up the question we asked the audience about you know, whether or not pragmatic and other point of care trial type approaches are viable for improving evidence generation, particularly in non-academic research settings. So getting kind of into some of these places that all of you talked about in your opening. So can we see those results? looks to be a relatively even split between maybe and yes. So a decent amount of confidence here. Obviously, a lot of caveats as to whether these trials are viable. So that's not too surprising that maybe is perhaps the strongest option there. Oh, it's going back and forth a little bit. So thank you to the audience for that. We'll feed that into our discussion. And I think we have a second question for this session that we might go ahead and open so that you can start responding to that as we continue our discussion. But for now, we can pull those slides down. So I might start and open this to anyone that wants to answer. Pam, you've been working on decentralized trials. We talked a lot about some of these other pragmatic and point of care trials, but we already had a question come in from someone watching. There's a little bit of a tension between engaging sites that might be trial naive or not really have the experience here, but recognizing the value in getting to new places to build a stronger base of diverse participants, but recognizing a low tolerance for lack of experience. So I'll open this to anyone. How are we thinking about balancing the desire and the need to get to more places with recognizing that there's experience levels vary, and how do we kind of close those experience gaps? Megan, I see you already raised your hand, so I'll go to you first.
Yeah, thanks. I'm sure everybody's got something to say, so I'll be quick. So I'm very excited about all the vendors entering this space. We know resourcing is a huge challenge at FQHCs and community centers, as well as even time to train. So we are seeing our partners like our CROs, PPD, they have these academies that can help train novel sites. We're starting to use that actually in Africa to help build infrastructure. But we're also co-creating education with our sites in the Site Alliance around cultural humility and unconscious bias, but even our AI vendors. So these AI vendors are doing amazing work being able to find where the patients are based on entry criteria and EHR records. But then we're like, how are you referring patients from community centers to academic centers? And they're very committed. Some of our AI vendors are putting coordinators on staff with the community centers to help them pull those patients through, should the site or the patient be interested. So I think our vendors are seeing this and are starting to step in. I think it'll grow, but I'm very excited to kind of see that. Also, we do have organizations like ACCC, they're heat mapping community centers who might be able to develop infrastructure, and their second phase is how can we help train them to do this work. I'm also seeing institutions like University of Illinois Chicago, who work in areas like Cook County, where the lifespan is dramatically different than some other zip codes, and they're working with their FQHCs on referral mechanisms, which I know is not point of care, but still it's getting folks in your backyard to come to places that are doing the site. So I'm seeing a lot of, just in the last 3 years, amazing things coming through from partners who are trying to help us do good work. So I'll leave it there, but for others to speak.
Thanks. Pam, I think I saw you wanted to weigh in.
Yes, thank you. I agree with everything Megan said. And additionally, I think some of the things are self-inflicted. Like, we have created systems that made it too hard for people for sites that don't have to be that hard. And a concrete example was during COVID, Laura Esserman wanted to change the iSpy network to iSpy COVID. And as part of that, they had, the hospitals already had contracts, so that was great. But the investigators were new. So instead of breast cancer investigators, you now went to ICU investigators who were treating COVID, and people were in the hallways. This was that time of COVID. And human research protection training typically is an 8-hour endeavor, which is a burden that we put on sites. But when we looked at it, we could pare that down to 2 hours. So some of it is just, we've done things always a certain way, but we haven't really critically looked at them in a while to kind of go, does it really have to be that hard? And so we were able to change it, and Laura talked to regulators to make sure that everything was in the up and up, and kind of was able to implement that. Because when you're in COVID and people are in the ICU, you don't have 8 hours to go train on human research protection. And you can extrapolate that to community providers. They don't have 8 hours to sort of go sit around and do this instead of actually treating patients. So I think some of it is us really looking at our systems and doing our part as an industry to make sure that we make trials more accessible, and that tension is a little bit different.
And Grail, you guys are using
Yeah,
the hand.
thanks.
It's so easy for me.
Sorry, I keep getting these weird messages because it's not. Can you guys hear me?
Yes.
Yes. Okay, great. Completely agree with what Pam was just saying. Incredibly important point. Just wanted to tag on to that and say that I think there's a really, really important kind of workforce component here as we think about going into communities when we're talking about research. And I know lots of folks on this call have already thought about this, would love to hear what others think, but when we think about integrating research into people's lives and people's healthcare at the community level, as we talked about as was talked about in the first panel, you know, how do we think about, you know, like what parts of clinical trial management can be done by people who aren't necessarily, you know, academically trained researchers, you know, like if I'm a phlebotomist, if I'm a nurse, if I'm a, you know, whatever it is, how can I, you know, what's a way in which I can participate in a clinical trial, maybe also be a patient navigator, you know, maybe also do something else that's going to help my community, you know, overcome a disease burden, you know, that my community is facing. And, you know, I just think that's incredibly important. And I know lots of you on the call have already thought about that, but wanted to raise that.
Thanks. Martin.
Yes, so I think you know, just to highlight, you know, the need for new sites. I think most folks probably already know this, but I think it bears worth repeating that about 50% of clinical trials are done in the same 2% of sites, right? So that obviously needs to change. And you know, and I think there are obviously legitimate concerns around the cost, the time and cost it takes to onboard new sites, and you know, sort of what that means for the development of the medical product being tested. But I think that you know, to sort of push the ball forward here, I think, you know, folks like us, I think we really have a big role to play here, in the sense that it is up to us, I think, to make the business case to those people who have that sort of decision-making power. And when I mean the business case, you know, why is this not just the right thing to do or the equitable thing to do, but, you know, how is this going to impact the bottom line in a positive way, in terms of dollars and cents? How is it going to reduce the number of adverse events when that product makes it into communities? And so I think we have that very precise and strong role to play when making the case for bringing on new sites, and specifically new diverse sites, you know, so that we can get those populations that are going to make the trials more diverse.
Thanks, Martin. Amanda.
Thank you. Yeah, I just want to echo, I love all of the points that everybody brought up. I think it's really important that, like, we've got all these super creative vendor companies that are helping fill in the gaps for staffing or training or necessary infrastructure for community sites. And I think there's a great opportunity to be really creative in thinking about that. I also really love the points about sort of the incumbent on the research enterprise to make the business case, and sort of being flexible about what we're requiring. Like, if a 2-hour training works instead of an 8-hour training, maybe the 2-hour training is okay, so it's easier for people to be there. I think that I like to think about sort of an on-ramp, if that's where that's possible to train up. And I wonder if we can tie it to workforce turnover as well, that it's really hard to train people and have them ready to do clinical trials. It takes a lot of time and investment. And if it's miserable and they're set up for failure, you have to make that investment over and over again. And so I wonder if we tie that to turnover and think of it as a sort of a longer term thing, that we're building reusable infrastructure, that makes it easier for us to think about how we can bring some of these new sites in.
Thanks, Amanda. Megan, last word on this, and we'll move on. You're muted.
I'll be very quick. Thank you, Amanda, for that, because we're seeing sites with strong missions to reach representative patients. They have longevity at their clinics. I just missed one thing there because of this high interest and awareness of the underrepresentation. We're starting to see our amazing site management organizations. I'm thinking of one in particular that have 3 Black women who are owning it and helping community centers, and they're doing the administrative lift. They're doing the contracting, the budgeting, the regulatory, and then if needed, they supply data management on these community centers. So they have the expertise to do the trials, and they are committed to training the community centers they're working with. So I think if that model can be adopted, and where I see it happening now is in our late phase trials. So our launch drugs, phase 4 trials, we're always willing to bring on new sites and train. We just need to do more of that and more consistently across. And then once they have that phase 1 experience, it's easier to bring them into the phase 3 and 2. So I'll stop there. Thanks.
No, that's really helpful. Thanks. Lots to pick up on from there. I think I'm going to go next back to our second poll for the audience and put that back up for a minute. I think this question touches on a lot of what you all just said as we think about what's kind of most pressing infrastructure-wise to support places like community hospitals and these other sites that we're talking about to engage in clinical research. So I think we can go ahead and go to the responses while we wait for maybe a few more responses to come in. While we're waiting, I'll also remind everyone, you can also use Slido to ask questions of this panel, and we'll feed those in as well. But while we're waiting for a few more, resources being, the clear biggest resources and time, perhaps as the biggest answers are maybe not too surprising. I see training and collaboration, funding, technology, the contracts and budgeting, Megan, that you already mentioned, organizations popping up to help support. Lots of responses here. I'll maybe pause for a second and see if anyone on the panel has any reactions to what you're seeing here before we move on.
Trevin, if I may, when back in city a couple of years ago, we did a project on why investigators only did 1 clinical trial versus continuing in clinical trials. These were people that had made the decision to do clinical research, but stopped after 1 time. And what we found is exactly this, that it was resources and time, that it just took a long time for them to participate, to do the stuff they needed to do in clinical trials. So I think this is a real issue. And if you're a community hospital or a community provider, I mean, you're sort of RVU based, and you need to produce work and get paid for it. And clinical trials isn't, I don't know. This completely resonates with the findings that we had for investigators who had decided to participate in trials. So I'm not surprised. Yeah.
Megan, I see you have your hand up.
Yeah, thanks. No, I absolutely agree, Pamela. I've mentioned examples for that, so I just wanted to pull up the EHR example, Trevin, because when we were doing the Skatori trial, which one part of it is completely virtual. It's been working really well. It's a virtual site, and there's virtual consenting, there's virtual surveys. But the toughest part has been based on the study team, the varying medical records and models. So the ability to be able to, and sometimes it's paper, sometimes it's different EHR record systems, the ability to be able to put for a decentralized trial, the ability to be able to pull in the patient records, it becomes very complex. So if I had a magic wand, one day our clinics would all be using the same EHR, right? We'd be able to lift that information, and that's a lighter lift for the site. It's a lighter lift for every aspect of study trials. And our AI vendors are telling us it takes about 2 months for them to program a unique EHR lift into medical records. So just that stood out at me as somebody put that in. Thanks.
Thanks. Grail.
Yeah, I would heartily second that on the EHRs. And I know a lot of folks are working on that. It's a long-term thing to try to line it up. We have a lot of different customized EHR systems, and it's often very hard to pull what you want out of there. But there's a lot of efforts underway. Obviously, the National Coordinator for Health IT, is working on this, and pushing forward the use of, FHIR APIs and trying to get standard structured elements into EHRs through US CDI and CDI Plus. Again, it's incremental, but it's really, really important to keep the pressure on there. And we've worked a lot on that. One other thing that I just wanted to add in terms of challenges, resources, obviously a huge, huge challenge. I also think that it's important as we move forward to try to think beyond the current conception of how trials should be sponsored and funded. Not that we have to throw out everything that we currently do. There's always going to be industry-sponsored trials. There's always going to be, trials that are primarily government funded. But can we think about situations where, for example, a bunch of different entities might all benefit from the data that's being generated, and can they share the work of mounting this, like a health system and an insurer and, the doctors and the community, it's not outside of our reach. And I think as we think about more pragmatic designs, we also need to think about not always assuming that the traditional ways of kind of funding and sponsoring are going to be the best. And that might also help drive buy-in on things like how we manage our records and integrating that into research.
Thanks. I think we can probably pull the slide down. A few minutes left still. So one thing I want to complete, I'm not sure I have a question here, but it's an observation from both this panel and the conversations today and the event that Duke-Margolis helped host last week. Martin and Pam, you were both part of that one as well, I believe. And we've had this infrastructure session here. We had also an innovative trial infrastructure session of sorts at that event. And in both of those conversations, workforce issues were one of the first things to come up. And I think on our part, in planning, we didn't necessarily expect the infrastructure conversation to also be a workforce conversation. But I think many of you and folks that we had at the event last week raised really important challenges facing the workforce, not just in the context of the representation and equity issues we're talking about today, but just in the trial workforce in general and challenge adapting kind of post-COVID. Amanda, I wonder if you might have anything to say about as you're planning for Enrich CT's work, are you thinking about opportunities to help providers that are interested in research, either by finding ways to make it easier for them or provide better training? What are y'all working on there?
Yeah, that's a great question. I think that it's in terms of specific things, I think workforce is a huge challenge as you've done this. I think that as you've outlined, I do agree. I think there's an opportunity, to be sort of thinking about sort of maybe broader training, broader education. I also wonder, and I'm interested in if anybody else has a reaction to this too, to pull in some of what the first panel said today. And I wonder if we can sort of broaden the idea of workforce so that, and I think maybe Martin or Pam said this, I'm sorry, I lost track, but that do we really need to have people who are canonically clinical research trained that are doing all of these tasks? Is there a way that we can ask our colleagues in community health work to do some of this? Maybe they're in a better position. And can we also elevate them so that they're sort of considered a critical part of this workforce as well, that there are partners that are helping drive it, and that they can have a say, that they can build that connection. And then we're also helping everybody take a piece of the pie so that it's dividing what we're asking of any one person to do. So.
Megan, go ahead.
Yeah, Amanda, I completely agree. There's been so many conversations at ACRP. So Susan Landis is leading a lot of efforts around workforce funnel. You mentioned, Trevin, as well as diversity. And that hybrid model for the trials is really helping us understand that. You don't have to have a medical degree and be a research nurse to do the coordinator positions. There are a lot of things that you could do, including phlebotomy, that doesn't require that training. So how do we increase the workforce for coordinators? That's a real issue right now, not just in the US, but ex-US as well, the rest of the world. So I would just add that ACRP is a great partner. So if folks out there haven't been working with them, might want to check that out. They have a lot of people thinking about this. And yeah, the whole virtual nature of hybrid trials, from using local labs to nurses. We now have some examples of using a central pharmacy to ship med. So there's a way we can distribute this work. One success key we have, and all pharma companies have this, is an access line, a trial information support line. They're housed with nurses, and in the virtual trial setting, with patient consent, they can actually answer questions for the patient. And they're even, for our late phase trials, all our late phase trials, they're managing the transportation service, so the site doesn't have to. So it's one less thing the site needs to do. So there's definitely some models around our access programs that are improving and helping patients in clinical trials. That's something everybody can look at today.
Thanks. Pam.
Yeah, so I think workforce is a big issue. And the other part I want to bring in, I think it matters to this discussion, is sort of the FDA guidance on DCTs that says you can use local healthcare providers. And sort of, if people collect data, that you don't always have to be an investigator necessarily, and how that could be a pathway to becoming sort of comfortable with clinical trials and starting to participate more and more, as a pathway to get community sites involved. And there's some issues in how you operationalize all of that, but I think it's one other way to reach out. Another thing I wanted to bring in is, this is when I started in clinical trials 30 years ago, we only had local labs. There was no such thing as a centralized lab. So part of this is not always new, and we need to remember that these aren't necessarily new systems. We just have to remember how we used to do them in the past, and that this worked really well for a long time, and that for control issues, people wanted central labs, but that can be dealt with on the back end as well.
Thanks. Martin.
Thanks, Trevin. So here at All of Us, we've one of the really unique aspects of our program is we're not just concerned with diverse participants, wanting those folks to enroll in our program, but we've also put an equal and super large focus on having diverse researchers access our data. And so because of that, we've engaged with HBCUs and MSIs, tribal colleges and universities. And so we have about over a third of our researchers being racial and ethnic diverse, and even a larger percentage when you include all those other demographic categories I talked about earlier. So how does that translate, how does that translate into the clinical trial space? Well, if you think about it, I think we all have colleagues here that diverse colleagues, especially racially and ethnic diverse colleagues that are in the clinical trial space. Not as many as there needs to be, but I think we've seen that many of those colleagues, they seem to have less of an issue recruiting diverse populations to their trials. And so sort of, if we take that same sort of principle and embedding the workforce diversity focus that all of us has and embed that into the clinical trial space, then I think, it's not unreasonable to say that, if we get more diverse clinical trials, more diverse PIs, that you're going to see some gains, therefore, in the populations and that are recruited to those trials as in being more diverse.
Thanks. Okay, we're about our originally scheduled session in time, but I know we get started a little bit late, so we're going to go for a few more minutes, as long as that's okay with all of you. I got a couple of audience questions and one more question of mine that I want to get to, and then we'll try to wrap up. First, an audience question that I'm going to rephrase a little bit. Do any of you have any input about the potential role of patient and community advocacy and driving efforts to build out better clinical trial infrastructure to support broader patient participation? Kind of where's the role for advocacy groups in this conversation to make sure we're getting the infrastructure that we need?
Well, it is critical.
Oh yeah, we're all going to jump in. Everybody's excited about this question. Yeah, I mean, I think they have a huge role to play. I think that that they can sort of keep us honest, so that the research that we're doing is actually reflecting the priorities of the community that we're embedding in some of the ideas that we heard in the first session around cultural competency and sort of, those things. But, I also think that, and I think maybe the next session is going to talk about this a little bit, but I think it's important for us to think about like, how do we elevate this to, and this is something we're thinking about too with Enrich CT, like, how do we elevate this to more of a B2B style relationship? How do we make it so that it's not like a transactional interacting one-on-one at a time with our community and patient advocate colleagues, but sort of having something sustainable, because they get into it's easy to get into a feast or famine where they have funding, they can build out a lot of infrastructure and do a lot of great work, and then the funding disappears and then they can't support that infrastructure anymore. So I think it's an interesting thing, and for us to think about sort of not only involving them, but involving them in a way that makes sense for a long time.
Thanks, Megan, and then Grail.
Yeah, thanks. No, absolutely. We need patients everywhere we are. That's why we're here. So ensuring we have representation in patient steering committees and patient insights work when we're designing protocols is really imperative. I will say there are also community organizations that are coming through to help their own community with health education. A couple are Acclinate in Birmingham, Alabama, serving their Black communities first with health information. And if they have any interest in clinical trials, bringing clinical trials to them. And Egality is one for Latino communities. So it's folks in their community wanting to improve health equity in their community. And they will invite us to be a part of the conversation, but it's their patients first and their communities first. And clinical trials is just maybe one component of clinical care. So there's some great mechanisms and groups that are coming forward that have trust with their communities, and it's holistically about health equity, and this is just part of that conversation. So that's an exciting area to watch.
Grant.
Yeah, just to add that patient centricity is incredibly important, and the advocacy groups can also help us shed light on as we think about trial design in different areas, like, what does it mean to reach communities in oncology? What does it mean in cardiovascular disease? There's definitely some commonalities, but as we think about designs that will get us into communities, I think advocacy groups have a particularly critical role to play in educating us.
And Pam, back to you quickly.
Yeah, so I would just like to add that this has also been recognized by the regulators. And ICH E8R2 actually has paragraphs around how you should be engaging with patient advocacy groups to ensure that your research is the right research, the right questioning, all the things that a quality by design protocol would require to have a better protocol. So it's also recognized by the regulators. Yeah.
Thanks, Pam. That's a great flag. I want to come back. Pam, you mentioned in your opening remarks that how we measure success with trials might be a little bit counterintuitive to how we get to representative trials, particularly around the first patient and metrics being so important. So I want to come back to that point and maybe Megan, see if you're willing to address that a little bit and see if there's, and open to anyone though, are there other ways of thinking about what successful enrollment, recruitment, retention look like in trials that are better suited to this representative work that we're trying to do, and are not, obviously we're not trying to extend timelines here, but is that first patient in really the metric that we're looking for? Or is it really more like when we finish the research study? Any thoughts on kind of Pam's comments there and what metrics we might want to be looking at instead to see if the infrastructure we have is doing what we want it to do?
Did you want me to go first?
Yes,
Sorry.
please, if you don't mind.
Oh, okay. Yeah, no. Well, first of all, it is not slower to enroll communities of color. We have many examples where we have exceeded expectations and brought a study in early because it was representative. MS Chimes, Elevatum, our Impacted trial. When everybody's aligned on reaching their community and you're geo-targeting sites who have the community and they're vested and you're offering proper patient support and you've designed a study that's doable, it is not slower. But absolutely, it's about last patient in when people measure, that point of decision making of whether you're going forward into the next step, right? Inevitably to get to all patients. hopefully something that'll address their unmet need. But it's definitely not slower. As far as measures of success, so I think all pharma companies are doing this, but we have a central trial diversity dashboard, and we are requiring diversity plans for all pivotal trials now. I know it's mandated in 2025, but now, so we can iterate and learn. And we're measuring those goals at portfolio committee levels quarterly. And teams are pulling that data in monthly. You measure what you treasure. And if you set your target goal to be representative for A and B and C populations based on epidemiology of disease, and you're out meeting that at month 1, 2, 3, 4, 5, you know this early, not at the end, not to bring in rescue later. So I do think measuring and communication and proper support of both sites and patients will help pull this in. But definitely FPI is the wrong measure. I think we all agree on that.
Thanks. Martin.
Yeah, so just to double down on what Meg said, Trevin, our mutual colleague, Jennifer Miller, she put out a recent paper where she showed that when you plan early for diverse enrollment, it doesn't extend trial timelines at all. And as Megan, she just rattled off a bunch of trials that said that, and the Platinum trial is another example of that. So I think really a focus, I think, on planning early is what it's needed, and really making sure those diversity action plans, the DAP, is as important as the SAP, really.
Great. Okay, and I wanna get us wrapped up so we can go to a very quick lunch break for those of us on the East Coast. But before we go, any last words from any of you on things we should have talked about and didn't, or any last points that maybe we wanted to make or you wanted to make that we didn't quite get to?
One very quick thing. I think one of the big challenges I know everybody's thinking about, but that I would highlight is operationally, whether it's pharma companies or government agencies, it's always very hard to think beyond the short term and think longer term when you're trying to change practices. I think that's something that's really important to bear in mind. So that would be my last word. Thank you.
I think I would add is there's really great momentum around all of this, and I think we're really on the precipice of sort of changing the way we've done things. And the quote I would like to add is we overestimate what we can do in a year, but underestimate what we can do in 10. And I think we should, we're really at this point where a lot of things are coming together to make this happen. And meetings like this will lead to action. And that is what's going to get us there. And I think that's why I'm so excited to be part of this conversation, because it's not just a conversation, it's an action that we're starting and continuing.
I certainly hope so, Pam. Megan, Martin, Amanda, any last words?
Yeah, just this conversation's global, right? So we are doing better at reaching Latino populations, thinking about country footprint, involving Central America, Latin America, doing a little better in the US, but we will never reach representation for Black communities if we don't commit to investing in the infrastructure of Africa and bringing studies there, training there. And there are amazing sites. There's some amazing sites there. So that plus biosample diversity, Trevin, if we can, and that's the beginning, right? Now, if we have underrepresentation in our biosamples, the researchers trying to find novel targets and understand disease better, we're missing out with 95% of patients' biosamples from European ancestry. So really important to diversify biosamples, get involved with the registries, socialize that with patients so they understand what it is. And, Mendoza. Martin, that's a perfect segue to you.
Yes, I think so. Martin, go ahead.
Thanks, Meg. Thanks, Trevin. I'll just end with a quick 10-second plug. It takes all of us. So Megan's already done her homework, but for everyone else on this panel on the call, please go to joinallofus.org, and that's something all of us can do right now.
Thanks. Amanda, any last word?
Yeah, I loved how aspirational we were in this conversation, and I think that's that's important. But I also want to lift up that there are things I think that actions we can take in the short term too. So we talked about some of them. Other ones that maybe we can think about is like we've heard really great stories of sponsors being flexible in terms of the requirements that they're asking of sites, because the sponsor requirements are not always aligned, and it's hard for sites to adjust that. So that's a small change in thinking that helps us move on towards the progress we can make in 10 years. So thank you, everybody.
Thanks so much again, all of you, for joining us today. We're pleased to have your time and expertise on this fantastic panel. For everyone else, we'll be coming back in about 10 minutes for our next session. And I think we'll be keying up maybe one more Slido poll over the break for the audience as well. See you all in a few. Thanks so much.
Hello and welcome back. I'm Marianne Hamilton Lopez, Senior Research Director of Biomedical Innovation at Duke-Margolis Institute for Health Policy. And in this session, it's titled Funding Considerations to Increase Representation in Clinical Trials. As we saw in the last poll, resources were an important consideration of supporting and building infrastructure. And if we are proposing that trials should and can be done differently and better, it begs the question of how we might pay for or incentivize these changes. During this session, our speakers will explore actionable pathways that funders can use to improve representation in clinical trials, including through the use of strategic investments and incentives. Our expert panel will also discuss potential business cases for representative clinical trials. As a reminder, we have an audience poll for you in Slido, and it says, who is most responsible for investing to drive better representation? Please use the QR code or go to slido.com and enter the code DIMI trials to participate, and we can review the results later in the session. Now, I am very happy to introduce this panel. I'm joined by Donna O'Brien, National Advisor of Manet Health, Jennifer Gibson Levy, Administrative Vice President, Education and System Academic Enterprise of Henry Ford Health, Jennifer Byrne, Founder and CEO of Javara, and Priscilla Pemu, Associate Dean for Clinical Research, Morehouse School of Medicine. Now, like we've done in previous sessions, I'm going to turn to each speaker for opening remarks. Donna, you're up first.
I believe, Donna, you're on mute.
Can you hear me now? Great, okay. Well, good afternoon. It's an honor to be part of this impressive panel presentation and part of the great discussions that have taken place. There's many places where clinical trials take place, and we heard a lot about that today, but I'm going to focus on hospitals and why hospitals, that's where more complex and early phase trials are offered. They can support many disease sites kinds of trials. With many as not-for-profit institutions, their mission is to serve the community. We know many do a good job at that. Many others need to get better skilled at engaging their community. And then many are in national systems, which offers a great opportunity for dissemination. So they're rich with opportunities for clinical trials. And then in terms of financial considerations, I'm going to talk about patients and coverage and financial related barriers, payers, and how they have some financial barriers that they present. And then for hospitals, how do they address the financial challenges of expanding trials, which we talked about in earlier panels. So on coverage and financial related barriers, we did a report for the Leukemia Lymphoma Society, but often when a patient seeks a trial or matches to a trial, it's outside of their regular source of care and often outside of their network. And when a patient is outside of their network, in order to be on a trial, they have to be accepted for clinical care. And if they can't afford the out-of-network copayment, they often have to decline participation in clinical trials. And that affects many middle class, all kinds of people that aren't able to afford very steep, sometimes $100,000 for out-of-network care to participate in a clinical trial. And then, Trevin mentioned the Medicaid Clinical Treatment Act, which has provides for Medicaid patients to have access to clinical trials. But when a patient matches or seeks a trial outside of their state, there's often barriers to participation, and that affects people with rare diseases, often with cancer, where they have to go someplace else to find a match. So that presents challenges and often leads to a lack of representativeness. So how can we promote clinical trials offered closer to where patients have their regular source of care and where it's easier for them to access and have fewer financial barriers? For payers, patients on a trial cost less money, but that isn't really factored in because when a patient gets presented to a payer for approval of out-of-network care or an appeal for their coverage, the payer doesn't even know that it's a patient on a clinical trial, so they only approve the care for the patient. So is there some way that payers can be incentivized or promoted, asked to have more studies on the reduction in the cost of care when a patient's on a clinical trial? There's been some work done in cancer around demonstrating sometimes it's a third less cost of care, and that could lead to different policies for patients on trials when they get put in the queue for approvals and open up avenues for more patients to get access to trials, especially diverse patients. And then for hospitals, a lot of discussion around the infrastructure needed to support clinical trials. We know academic medical centers are the place where most trials are offered, and they have the infrastructure, but many times their infrastructure isn't that efficient, and there isn't enough investment in supporting the clinical practice culture or all that's needed for that infrastructure to work efficiently. And when it doesn't work efficiently, they don't enroll well. And when they don't enroll well, they don't make the revenue they expect. And it's a cycle where they end up not having enough infrastructure to really optimize what they're able to do. But we heard a lot of conversation around community hospitals. And I think they're a tremendous resource that's untapped. Clinical trials are not mission critical to them because they focus more on advancing health and not advancing science. But they're a place where trials can be offered at the point of care and for all in their community. And as I mentioned earlier, many are in systems. So when you have hospitals that are in a system do a good job on clinical trials, it's easier for that to spread more quickly across their system. And many have hundreds of hospitals now, some of these large national systems. But we know, bringing trials to the regular source of care can increase representativeness. So that's very important. And I wanted to note one example of a success in this area is the NCI Community Cancer Centers program, which had 30 hospitals participate over a 7-year period. And 40% of the funding was to be targeted to health equity and increasing representativeness in clinical trials. And a critical factor was engaging hospital executives in supporting that program because they establish priorities and they control the resources. So that was one of the factors that really led to the results, which are well documented in many publications. But one quick anecdote was when that program was kicked off, all the CEOs of the 30 hospitals had to come to the NIH. And most of them said they never thought their career would even bring them to NIH because they didn't think of their role as being part of science. And they found it very exciting. And I think that's just a perfect example of how we have to connect the institutions outside of the academic medical centers to science. So the questions to leave with are, how can we better support the development of a business and mission case for investing in a clinical trial program that can increase representativeness? And then how can we get trial sponsors to view community hospitals as places to invest in partnerships? I know there's questions about naive sites, but there's a very great track record of community hospitals being able to do a good job in clinical trials, even early phase trials. We just have to help them create the business case, which is retaining their patients and actually retaining and recruiting their physicians. So I think there's tremendous opportunity and look forward to speaking about it more in this panel.
Thank you so much, Donna. I'm going to turn next to Jenny at Henry Ford.
Hi, everyone. And I'll just also say that I have a master's in public policy. So this is like the most exciting thing for me to be able to talk to a bunch of other policy people about policy-driven solutions. So, and it's not something I get to do every single day. So I am very, very happy to be here. So I worked very closely with Donna, actually, and in terms of initiating and really driving forward and operationalizing a lot of changes that have driven increased representation or representativeness in clinical trials and expanding our clinical trial footprint. I just want to kind of piggyback on what Donna said and really talk from my own institution's perspective. Providing access to cutting edge science and innovation and procedures is completely like the mission of what Henry Ford does. And just, you know, basically being able to do that for our community essentially drives a lot of the objectives that you all are talking about today. So I think for me is finding ways to partner with institutions that are like Henry Ford, and there are many across, you know, the nation. There's one in, you know, every city. There's multiple in, you know, in different states. I think finding that type of a phenotype of an organization that is deeply devoted and embedded and trusted within their community, and also very focused on innovation, academics, research, education, I think really is, and then understanding what are the barriers that are making expanding clinical trials and achieving success in clinical trials to make those trials available to their patient population is really the kind of like the kernel of the problem that we're trying to solve. And so we definitely haven't figured everything out yet, but a big part of what I was brought to do in my role is to look at these types of things differently. So I will try to, when I'm talking about solutions or, you know, what we're talking to really try to be very granular and talk about really case studies in terms of what we were able to achieve and what, you know, we still struggle with achieving. But generally, you know, I think finding the right partner is honestly like the more important question than who is the responsible funder. So finding the right partners in a community. And I think hospitals and hospital systems are great partners because they already have developed the trust. They already have developed the networks. And so, you know, really partnering with them, whether it's pharmaceuticals, whether it's government on the state, local, federal level, is really a way that we can scale this up and make discovery and innovation and science and breakthroughs available to the many, not the few.
Excellent. Thanks, Jenny. And I think we welcome kind of granular examples, and especially as we're trying to move forward to some very actionable next steps. Jennifer, I'll turn next to you.
Good afternoon, everyone. Yeah, thank you for including me in this discussion. And I thought it was an amazing comment that Pamela ended the last session with when she talked about that tendency to overestimate what we can do in a year and underestimate what can actually happen in 10 years. And in a way, I'd just like to say, gosh, I wish that I would have had an opportunity to experience this forum 6 years ago on the eve of launching Javara. So many lessons learned. And when she said that, it really did, you know, resonate. And, you know, Grail also talked about, you know, kind of the short term versus the long term. You know, I think from a really pragmatic standpoint, I can tell you, you know, again, just a little bit of background. Jennifer Byrne, I started my clinical research journey, and I would consider myself to be a lifelong clinical trialist as a research coordinator long ago. Founded, you know, Javara really at the heart of trying to bring forth, I'm going to say, a more modernized business model that from day one was really built and constructed around partnership, as Jennifer just talked about. I mean, really the partnership to be able to enable clinical research at more of a system or a healthcare organization level. Donna talked about the importance of executive sponsorship, because ultimately that's where the power brokers to patient access and ultimately trust in terms of allocating the resources and prioritization. And when you have that in an organization, then I think some of the things around just practical considerations about how we can actually make this easier for physicians and physicians within the community who are really the trust brokers, you know, to be able to operate. So, you know, at the heart of, you know, what we really set out to do, again, was, you know, build a, you know, a partnership model, but a very specific bespoke model around, you know, this intersection of research with care. It's interesting to me as you know, this program has broken out the topics as we've kind of gone through the continuum of topics. You know, what is the continuum around targeted outreach to continual community engagement? How are we thinking about building and scaling innovative clinical trial infrastructure? And now, you know, we're here talking today about funding considerations. I'm going to just really say, you know, I think it's almost the reverse. Lessons learned for me in 6 years. And this was a very mission-driven organization. I mean, people ask about our business plan all the time, and I'm a lot more interested in talking about what our manifesto was all about, you know, which was really at the underpinning that clinical research has changed the world. You know, historically, we have had missteps that have eroded trust. But let's face it, I mean, clinical research promotes, you know, well-being. Clinical research, you know, is an indispensable part of our humanities well-being. I think this discussion today is so important that we're making sure that it's reaching everybody's well-being, for example. So, you know, the practical considerations around this, and they've been really well covered. You know, the last panel especially really drilled down, for example, on workforce. I will say from a funding standpoint and thinking about this as a business proposition, and I don't want to, you know, rub anybody the wrong way, but there is no mission without margin. And, you know, we absolutely have to be thinking about these funding mechanisms and not just in one giant bucket, but, you know, what are the levers around investment? And in our particular journey, you know, this investment is becoming more and more clear that what is the investment to promote investigators, you know, and physicians who aspire to either promote clinical research or actually be involved as investigators. It was great to hear Genentech's commitment in terms of some of the resourcing around accelerating, you know, physician adoption of becoming investigators, but it does come at a cost. And I think that this is, you know, from a funding standpoint, I also want to make the point, it's not a they, this is not a they issue. You know, we'll be interested to see what the poll says in terms of who should be funding this, but just kind of out of the gate, I think it's very much a we issue. And how are we together thinking about, and across the various stakeholders, who does have a hand in helping fund just investigator development? Workforce, that was already, you know, really well covered, but it is, as Perla talked about a little earlier, you know, it is a very specific skill set. And how we are thinking from an HR strategy, for example, just talent acquisition, how we're thinking about building internship programs with HBCUs, for example. Those take targeted resources and they certainly take time. And then finally, you know, the funding mechanisms around community. And it's interesting, you know, I was talking to one of our investigators who is an African-American physician in Fayetteville, Georgia, who 5 years ago had never been involved in a clinical trial. And I'm very proud to say 5 years later, I mean, she's a rock star, you know, just kind of across the board, you know, running a lot of trials. But it's interesting because this definition around community, and we've talked about community outreach and development. I think so many times we think about just going to those unknown patients who haven't been reached, or in fact, perhaps they don't come forward because they don't trust. But another component around this infrastructure and funding is also reaching the other physicians, the other community leaders, and how are we, providing innovative ways in terms of providing funding resources to the causes and the needs that are important to them.
Excellent. Thank you so much. All right, now I'll turn next to Priscilla.
Hi, everyone. Priscilla Pamo here in Atlanta, Morehouse School of Medicine. I'm really glad to be here, to have listened to the earlier sessions. I agree with a lot of what has been shared. What I will share is our experience in building capacity to be a strong participant in this arena, mostly because when I had the outreach, it was a specific ask around a program called Beacon of Hope. So Morehouse School of Medicine, for those who may not be aware, is a historically Black institution, is a historically Black medical school, one of 4 in the country. It's community-based. So even though technically we could check the box as an academic medical center, those who are aware of who gets the funding really know that that is not something that is a huge strength that we have. And so when we had this opportunity to partner to build infrastructure around clinical research, clinical trials, it was a huge deal. This came out of this season, the social justice discussions during the pandemic. We had outreach. Over the years, we've had interest. We've always had a strong reputation in the community in terms of what our mission is, which is very focused on health equity. And it's a very holistic mission. So developing workforce, developing people who will go back out into the community to provide care, finding people from the community to equip to do that work. That is what Morehouse lives and breathes every day. And so we've always had that trust and that relationship in the community. And so when this happened, I guess it was 2020, 2021, we were approached. And the question that we were asked was, what is your challenge? What is it that you need in order to become a stronger player in this arena? I thought that that was a unique approach. In the past, we would get approached to participate in clinical trials when the diversity numbers were poor, and they're looking for a backup site that maybe has a potential to increase diversity numbers. So that always had us starting at a disadvantage in the sense that we still had those somewhat slow processes for study startup. And so by the time you made all of that effort and expended the effort to do that, to start up your site, they would come back with, oh, well, thank you, we're done now. And to the point of the metrics that's being documented about you as a site and what you're able to do and what you're not able to do and your desirability as a site. So those were all headwinds that we were facing. It was really great that with Beacon of Hope, essentially there was the question asked, what is it that you need? And so we had the opportunity to get into a long discussion, a co-creation process, where we established what our goals and ambitions were. Ultimately, obviously, the funders of Beacon of Hope, led by Novartis Foundation, wanted to have the opportunity to have expanded diverse participation in clinical trials. What I really appreciated about that approach, I think it encapsulated a lot of the different elements that have been spoken about earlier today. So it wasn't a transaction, which is what a lot of these discussions tend to look like. Rather, it was, hey, what do you need? So there was the desire to hear what our goals were and what is it going to take to get there, understanding that everyone that's bringing a perspective to the table has an expertise in what they're bringing to the table. And so what this commitment is a 10-year commitment, which means we have time to build and to build on top of what we're building. In addition to that, there are metrics. And so, you know, you can set goals for, you know, the first year, the second year, the third year, and we're approaching it at multiple different levels. So from the level of our community engagement, what those resources look like, what that process looks like, what the science of community engagement could be, to all the way to what is it that we need to do in terms of our study startup processes, what do those need to look like, what are existing metrics, how can they be improved, all the way to what's our issue with having potential investigators or the study teams, what is standing in the way, so spending time to look at the problem and building solutions based off of those. So we are 2 years in. It's very exciting, and it's expanding our capacity. We have the ability now. I think what is unique, speaking to the point that Jennifer brought up with respect to investigators, right now, for those who know, if you're a physician and you're in patient care, there's almost a disincentive for you to do anything that's not generating income, or those famous RVUs. And so for a lot of investigators or potential investigators, there are hurdles. And so one of the ways that we thought about approaching that was in building research fellowships. These are funded outside of the usual funding for GME. And this has been very, very helpful. So happy to share a lot more detail. I'm really glad about the tenor of the conversation, the depth of the conversation, and thank you for including us.
Thank you. Thank you all for those opening remarks. And I do so appreciate the examples, and because we're going to have to get granular and think about how we can scale some of these really important lessons learned and people who are actually doing great work already, if we want to make some really impactful change. We're going to take a quick look at our Slido results. Again, we were asking who is responsible for investment. Okay, all right, so as you can see, we have a great amount of people saying everyone, which I think as far as reaching our goal of collaboration, that really does means that we're having the right conversation, that this is involving everyone for us to be successful. We are going to push a little bit more, you know, especially as we're trying to think of some policy solutions. If we are going to say back to the different stakeholders, you know, if we all want to be responsible, you know, this is the way that sponsors could be, you know, working towards better investments. This is where the government should take a greater role. So I think that's what we were going to take from this conversation at Duke-Margolis, to think through what are the responsibilities, what are the actions needed from all of these various stakeholders. Because as you can see here, it's really a belief that it has to be engagement through across the ecosystem. So we're going to move now to our panel discussion. As a reminder, you can submit your questions on the Q&A tab. We've already gotten some really great questions that I will try to move through into the general discussion. The first question I have is, what innovative funding models or incentive structures do you think would be most effective in promoting diversity and inclusion in clinical trials? We've already heard some examples here. And Donna, I want to start with you, because I know you've spoken in the past that we can't necessarily think or follow the traditional academic centers approach. If we're saying we're doing something different here, we are going to need to look more creatively or look in different places for those incentives, for those investments. Could you go a little deeper into what are some models that we should be exploring if we really say that representation is our end goal?
Yeah. And I know Jennifer and Jenny can add to what I'm going to say, but I think, you know, community hospitals is really where the greatest potential. I know for cancer, as an example, 85% of patients are in the community. And the starting point is most leaders in community hospitals, and I'm a healthcare executive, they don't know what good looks like. And Jennifer Byrne can confirm that, you know, they don't know what a good clinical trials infrastructure looks like, or the clinical practice culture that Priscilla mentioned even looks like. So that's part, and Jenny knows that too, because she's working at Henry Ford in the infrastructure is what someone in research designed it to be. So first is educating about what a good clinical trial, what a good program looks like, and the investment that's needed. And then the other thing is in healthcare, if you perform a cardiac procedure, you might get paid 60%. But on a clinical trial contract, if you perform, you get 100% of the contract. And most CFOs don't realize that you have to make it possible for you to perform on the contract so that you have money to reinvest in your infrastructure. So I think there's a lot just around education of what good clinical trials looks like, and then finding ways for your physicians to not be penalized for participating in research. And then there's a business case for when you do, as a community hospital, you retain patients, you attract patients, you retain doctors, you can recruit doctors. So I think it's really creating what does it look like that's good, and how do you make a business case for it that's successful for your organization.
Great points. Does anyone else want to add on?
Just a couple of things. One is that as far as just kind of innovative funding, just some progress to share with everybody. So we started incorporating, we started investing as an organization from day one in terms of ensuring that our patient enrollment was representative of the communities for whom we serve. We partner with healthcare organizations, whether it's academic learning health system, whether it's a national practice management organization, independent large multi-specialty physician groups, and we even have a federally qualified health system. So that definition is pretty broad, but our aim really from the beginning was that, you know, we would, you know, build the infrastructure and the mechanism that truly our clinical trial enrollment would be representative at the local level, which obviously would be very different in Houston, Texas than it is in Annapolis, Maryland, for example. But a year ago, we really, and we needed to find ways to support this from a funding standpoint. From a pharma standpoint, as we know, you know, by and large, the funding mechanisms come based on randomized patients. About 10% of our revenue comes kind of outside of that for study startup and just, you know, kind of alphabet soup of everything else that happens. And, you know, therein lies a conflict and a challenge. So we started implementing an ask around a line item community engagement fee. So one by one, every single contract that we would submit, we'd have a line item, patient engagement, or I'm sorry, a separate community engagement fee. And we were less successful more of the time than successful. But in 2022, that number was 2023, that number was 14%. If you fast forward kind of a trailing 12 months and you look at that success rate now is 77%. So, you know, I want to do a real shout out to, you know, the pharma companies out there in particular, not all of them, but there are some trailblazers out there that are, you know, really putting direct investment, and it does, you know, provide a direct mechanism for us to invest in getting into the community, not as a recruitment strategy, but as bridge building. And, you know, as a mechanism, in the way I look at it, to better empower healthcare consumers. And better empowering healthcare consumers comes with education and then access points. So that's one. And then I'm going to say just a play, perhaps Priscilla on Beacon of Hope. Another play on Beacon of Hope, I am going to say there is a beacon of hope in terms of, I think, some movement that we are starting to see even within academic and larger health systems. I talked to one of our research investigators yesterday. We've been working with this particular institution within the Department of Infectious Disease, within a large academic center for 5 years. And he said, finally, after 3.5 years, so it took a year and a half, I'm sorry, it's only been within the last year and a half, that institution now has a mechanism for providing more direct funding at the department level. But I think it's taken partnership. Jennifer's talked about the importance of finding right partners. I like to think in this case, we found a really good partnership together, because I think together we have been able to surface for the institution an expanded value proposition around research. Which is not just measured, in terms of revenue dollars and how well fixed costs are being covered, but truly around, how is research actually bringing new patients who otherwise have not been connected to the institution through research.
Excellent, thank you. I want to take a moment. Some of your comments from across the panel were about kind of a misalignment of incentives. And I think Donna and Priscilla, you both talked about especially that for kind of care, clinical care and engagement in clinical trials. One of the questions from the audience is a really, could developing rural hospitals, or maybe we could say more broadly community hospitals at financial risk into clinical research centers, serve dual purposes of stabilizing healthcare in rural areas, as well as increasing representativeness of multiple factors. So I'd like to hear about, what is that a good strategy for addressing some of the misalignment of care, or a way to bring the trial closer to care, or do you have other strategies that would address that misalignment? Priscilla?
Thank you. I think that that's an interesting thought. I will ask a question around that to kind of see what the thoughts are here. So on one level, definitely it makes a lot of sense, right? If this is something that can be put in place, then maybe those safety net hospitals that are closing in rural areas that's causing deserts for healthcare will be addressed. A challenge that we have encountered, a question, a concern that has been expressed is this sense of, are you targeting us as a community because we have needs? And so because of that concern, because the safety net hospital or the people running those hospitals hear that concern, there is a hesitation to have clinical research front and center in their conversations around the business that they're going to do in a community. I think that there is a way to address both needs. Obviously, it's going to take full engagement with the community from the ground up, even as you're planning, full transparency in what you're doing. But I think that it solves multiple problems, but we have to be clear about what the potential challenges could be.
And I'll just kind of also chime in, like at Henry Ford, for example, we're a 5-hospital system with multiple other sites. 99% of our clinical trial activity happens at our main hospital, which is also our academic center. So even a place like Henry Ford, which is integrated into a health system, we have challenges with bringing clinical trials to where people live. And, and part of that are, for like reasons that are just so, they would be so clear to like somebody who's familiar with academic medical centers, but, and this is some of the things that we've really been working to change. So typically in the past, our research administration has really been focused on federally funded NIH, R01 grants, which is really the coin of the realm when you're talking about, basic science research and things like that. Clinical trials are kind of almost a separate beast, a separate animal, even though from a patient's perspective, I don't think they would be very different, but that from an institutional perspective, they're very different. So, when you're wanting to talk about where clinical trials typically live, a lot of the infrastructure was living in our departments, and the departments are very highly focused on the academic center hospital. So one of the things that we really did to be able to expand scalability, and then this really is about, you can get to the innovative funding models this way, is we really work to centralize and really improve, I say, customer service of our, back office functions and study startup. So to be able to make that as easy, efficient, seamless as possible, and really remove the barriers to entry to get patients on trials and to get patients on trials quickly. But all of those things they require investment, right, up front to be able to get to that point. And in the past, most things have really been investigator initiated, so they're just essentially unscalable. So I think it's really looking at things in more of a holistic point of view, and how can, I think Jennifer Byrne talked about this, like how can policymakers really encourage that investment in the infrastructure, in what makes clinical trials occur, to enable institutions like Morehouse, like Henry Ford, which is already doing this work for their patients, to be able to offer clinical trials and clinical research to everyone that would like to be a part of it.
And just as a form of clarification, and then I'll turn to you, Jennifer, is when you say investment that's happening now and how you're trying to remove those barriers, is that primarily coming from the C-suite within the hospital, but you're saying it needs to go broader?
Another big part of this that we really haven't talked about is philanthropy and endowments. Those are a huge part of what makes academic medical centers be able to do this.
Okay.
Research, but I don't like to say this, but it's true. Like research, if you look at it just on like a balance sheet, it does lose money. So a lot of times in the C-suite, it's hard for them. Like there's a ton of benefits and there's a ton of other things, but when they're just looking at it, on a P&L, sometimes it's hard for them to justify that versus other things that bring in clinical revenue. So, endowments, partnerships, investments, grants, those are all absolutely required things to be able to get to that scalable level where you can achieve this.
Great, thank you.
I was just going to go back on the misalignment question, because if you think about Jenny's got academic plus community. If you think about a rural hospital, which you gave the example, and a physician takes an interest in doing a clinical trial, so the misalignment is that physician has no one supporting him or her in doing that trial. So the answer is to kind of bump it up to an organizational commitment. And when you bump it up to that level, you say to the executives, if you invest in clinical trials, you're going to retain this great physician, or you're going to be able to recruit other great physicians, and you're going to be able to keep patients that are usually commercially insured from leaving to go to other places. So I think the misalignment, usually it's a physician kind of fighting for whatever time they have to do this work that they're devoted to, but with no organizational support. So getting organizational support and then having the organization look at it from a more strategic perspective of what is investing in clinical trials really help to align your goals so that you benefit, the physician benefits, the patient benefits.
Or even clinical, even pharmaceutical companies, like that the funding is based on enrollment. There's a lot of, and some study startup, but there's a lot of things that have to go into it before you even get to that point, right? Before you can enroll and before you can accrue. And, I think that Dr. Pima's experience is so relevant. And it was the same for us, you know, like basically when you're, you know, the study might already be closed by the time that you've gotten to the point of achieving those barriers, or not being, you know, included at the very first cut of the research, of the clinical trial being initiated. And so like being like really, I think policymakers and pharmaceutical companies and industry thinking about this in terms of like, what are the things that can make, like, that can remove the barriers to entry and make it as easy as possible, and build that culture of research in institutions that already have that mission and trust within their communities.
Yeah, I think just to kind of add in terms of, you know, kind of building on the component around misalignment, I think it's getting really clear from a business case standpoint. And as we're thinking about partnerships, and I'm going to say funding, you know, partnerships, you know, is community engagement from a pharma level, you know, is that getting funded out of a clinical department budget? That is no matter what. I mean, the return on investment is centered around patient enrollment and retainment. You know, I think really being super clear that in terms of the investment that is needed for the long run, are there those opportunities, perhaps even within some of those same pharma companies, but that perhaps is a foundational route. You know, going down the foundation versus looking at your funding from, you know, clinical, you know, account are two very, very different pathways.
You know, I was going to pick up one thing to comment on for community hospitals is the easiest trials for them to do are NIH trials, because there isn't as much involved in managing those trials. So, but they really to offer their patients, they need industry trials. And this is where like Jennifer Burns' model comes in. You know, organizations, they can try to build it, but it's really hard to build all those regulatory functions in and train all the staff. So if, you know, if they really want to, they need to move into industry trials. It's such a big leap that they need more funding and help, or they need to consider buy versus build models like Jennifer is doing and other companies are doing out there.
I think in fairness though, Donna, I mean, I just, you know, from the poll, it was interesting to me, the one stakeholder that was not mentioned, and I would be totally remiss if I didn't do a shout out. I do think that we are seeing more and more the role in terms of the investment community. So Javara started 6 years ago. We were really self-funded. We were very scrappy. But at a certain point in time, again, I'm going to go back to Pamela's, you know, the underestimation of what it takes. At some point, there was the realization and the opportunity in terms of getting to the 10-year view. And so as an organization, you know, we have investors, and we have chosen, we've been very selective about the investors who we have had, and those investors having the longer view. So, you know, I think there's, you know, kind of a growing movement too from, you know, the investment community, which sometimes gets a bad rap. But, you know, I do think that there is a world out there of investors that are very, very aligned, and there's a, you know, a role and active involvement in funding this as well.
These are just really amazing points. And, you know, I think I do have a question kind of as a follow-up. If we are saying the investor community or kind of working with pharmaceuticals, if you were a community hospital and you want to be taking this from an investigators-led idea to the organizational level, how would those conversations even begin when you know you need to start bringing in pharma, you need to start thinking about investors or even philanthropers? Is that something that community colleges are ready, community hospitals are ready to do?
I think what happens is pharma reaches out to the physician investigators, and it never goes higher than that. So we're an advocate for, you know, getting management engaged and thinking about it strategically. So I think trial sponsors should help. What are the elements of the business case? What does a good clinical trial program look like? I think they need to be at a strategic level meeting with executives. And I don't know, all the ones I speak to, some are represented on this phone call. They just are so tied into the investigator. And then they use CROs as the intermediary that interface with investors. So I think executive engagement is really critical. And I know Jenny and Henry Ford, it was executive engagement that's enabled them to leapfrog ahead. Before that, it was just physicians paddling upstream. So that would be my.
It ends up being kind of an entrepreneurial exercise when you start at that level, rather than being something that I think is scalable and provides the type of change that we all want to see.
Great. One question, is kind of combining two that we have from the audience right now, and I want to think about it through policy levers. And so I'm going to try to put two ideas here together, and you can respond to either or more or broader. But what are some of the levers we could do, maybe on a national or kind of in the payer world, that would address some of these misalignments or these barriers? So can you see the FDA, this is from the audience, under the new trial diversity expectations, setting requirements on community engagement review of protocols and designs? Could that be a financial reimbursement that could be used as a potential carrot? Another one, is there any ways that we could reduce the barriers around patient healthcare coverage and its linkage with the clinical trial landscape, realizing that's not how it's done internationally? Is there a bigger voice that we should be looking at from the payer community or CMS that could be, again, something that could address that specific barrier, Donna, that you started with, about where we have coverage and how that might kind of inhibit an ability to participate in a trial? So either of those resonate with any of you about potential levers?
On the first example of kind of the FDA and community engagement for clinical trials, you can't separate an organization's community engagement overall strategy and the reputation they have in the community and trust. So if you gave money for that, it's very hard for a clinical trial operation within a hospital to impact community engagement. So I think money has to flow to support that, but you have to recognize that it goes back to the organizational commitment that's really critical on that. And then, it's tied in with population health, which is getting to be much more important going forward. And then on the insurance barriers, I was thinking that we've been thinking, we did work with the leukemia and lymphoma. Could you gold card, if you will, patients on clinical trials, so that when they went in for approval, they would be flagged immediately that they're clinical trial patients and given a different process for reviewing their cases, because it's a small number of patients. And the other thing is for the payers to be encouraged, and I think the federal government could do this or fund studies that show how much money they save when a patient's on a clinical trial. And that becomes the argument for gold carding these patients, because otherwise I don't see a way of, and I guess the ultimate solution is care close to home when they're in their network. But absent that, I think some kind of gold carding and data to show how much patients on trials funded by pharma save payers money.
Great points.
Yeah,
Priscilla?
also,
Go ahead, Priscilla.
You want to go ahead? Okay. Thank you. It resonates with me that if there is a requirement to have diversity plans, that there ought to be a line item that addresses that. Not the assumption that it's going to get covered somehow. I think that really resonates for me. I don't know how it gets done. I'm not a policy person, but I think it's an important line to draw. With respect to figuring out a way to make sure that people are able to get care close to home, that the fact that they're participating in clinical trials is recognized, I think that could be double-edged in a way. It would be important to hear from people how they feel about being marked in some way, right? Having a spotlight on them in some way. how that lands for them and how they feel about it. I recognize that there's value from the perspective of the insurer knowing and things like that. But my first reaction, my gut reaction, Donna, when you said go-karting was just that, I wonder how people would feel about that. So I think it's a good thought, but I think it needs to be explored from the perspective of the person who is going to have a light shown on them. Those are the two thoughts that I wanted to share. Thanks.
Most of the patients are frustrated that they're getting denied, though. So that's where, because we did all these patient focus groups on this, and they would appreciate the payer considering their request to be funded on a clinical trial. That's kind of where it's coming from. It's not like a labeling. It's just saying that that they shouldn't be turned away without further consideration.
Understood.
I could just add from a policy reform standpoint, I wonder, I'm really curious about this, and it kind of goes along the track of modernizing, clinical trials, decentralization. I mean, there are so many models underway. I mean, the practice of healthcare has changed. Not so long ago, it was very physician driven. Physicians were independent operators, except those that were, linked to academic, medical centers. And I just wonder what would the implications be, for example, on a 1572, if ultimately the responsibility of the clinical trial and oversight of the clinical trial did not lie on one investigator, because one investigator doesn't necessarily have the bandwidth or even the span of control in terms of democratizing access across a much broader organization. What would that construct look like if it really was more an organizational responsibility? Because clinical research is clearly a team sport now, I mean, in a very broad way. And I think that, that kind of archaic way of thinking that a physician ultimately has complete oversight responsibility. I mean, we are living in a world where there's far too much complexity on so many levels. And so again, if we, started thinking about it a little more broadly as opposed to so individual centric, would it change prioritization and resourcing?
So I thank all of you. We are at the end of our session time. And I want to thank you all for what I have seen just to be a fantastic discussion. And so a common concern we often hear from folks when we're talking about this space is that it's so hard to, we might be in agreement, but it is hard to make change. So appreciate everyone's willingness to give some really granular examples about what's worked. Love to hear lessons learned. What I think further research would be, if 6 years ago, what would you have loved to know, Jennifer, that we could think through as other organizations might be in similar places, that they want to make the change. They know they're going to be interacting with new partners in the investment community, whether it be pharmaceuticals, getting their C-suite involved and trying to make themselves, as Priscilla and Jennifer both said, ready so that the clinical trial doesn't pass them by the time that they're ready to participate. So I think there's so much that can be explored. And also just how important it will be that with any policy solution, kind of going back to your point, Priscilla, that it will also then think how will this be perceived? How will this be, accepted or not by the communities that we're trying to serve? And how can we make sure through focus groups or the community engagement that we heard in the first session of today's webinar, that we are bringing the right people to the table with any kind of policy recommendations that we move forward. So I really appreciate the conversation. I'm going to be moving us to our final session of the day, which is Future Reflections, which will be moderated by Salima Al-Amin, who is the Assistant Director of Equity and Research at Duke University's Clinical and Translational Science Institute. So thank you all.
And thank you, Marianne, for that introduction. Hello, everyone. I'm Salima Elamine, and I'll be moderating our final session of the day, Future Reflections. While there is no audience poll for this session, we do encourage you to submit all of your questions via Slido throughout the session, as you've done throughout the day in previous sessions. And so please make sure that you submit those questions. And during this session, our panelists will reflect on the themes covered throughout the day and reflect on how to turn priorities mentioned into action. And so now I'll take a few minutes to introduce our amazing panelists. First, we have Mimi Fenton, the head of clinical design and strategic growth at Walmart Healthcare Research Institute. And then we also have Adrienne Martinez Hollingsworth, the director of research and evaluation at Alta Med Institute for Health Equity. And then we have with us Michelle Reed, Senior Director and Head of Global Demographics and Diversity at GlaxoSmithKline, which we're so excited to hear from. And then we have Barbara Bierber, the co-founder of Brigham and Women's Children's Hospital at Harvard's Multi-Regional Clinical Trial Center. And then Carolyn Shore, the Director of the Forum on Drug Discovery, Development, and Translation of the National Academies of Sciences, Engineering, and Medicine. And so now we'll begin with panelists' opening remarks before we'll move into a brief discussion as our time permits. And so we'll have a few introductions from Mimi.
Hi, everybody. Thank you for having me here. It's a real pleasure to be here. Mimi Fenton. I'm at Walmart in our Healthcare Research Institute, and I lead our strategic design and research science teams. The focus in Walmart with our Healthcare Research Institute is thinking about how do we engage our communities in clinical research, and specifically thinking about clinical research as a care option. And what are the ways that we can leverage the Walmart infrastructure and the Walmart data to be able to engage our patients, to bring clinical research opportunities to communities, and to give patients an opportunity to access innovative medicines that they wouldn't necessarily have the option to access without that infrastructure in place. And really working very hard to understand what are the ways that we can contribute to ensure that the patients who participate in the clinical trials really reflect the patients who bear the burden of the disease. How can we ensure that clinical trial populations reflect the epidemiology of the patient population? And then thinking about how do we leverage our data and develop the right tools to give our patients a voice where decisions are being made. And I appreciate all of the remarks that the panels have given up to now, and that's really been our focus, thinking about the ways that we can integrate different organizations and the different silos that potentially exist to be able to weave together the right story for our patients. How do we incorporate the patient voice into the protocol design? How do we ensure that sites and investigators are being selected that are representative of the patient population? And how can we make sure that really the communities in the United States are the ones that are able to have the opportunity to participate in clinical trials and have that voice?
Next, Adrienne.
Hi, everyone. Wow, this has been a really thrilling day, I have to say, especially that last group. I have so many reflections on what was said. But first, to just introduce myself. So I'm Dr. Adrienne Martinez Hollingsworth. I am the Director of Research and Evaluations at AltaMed. We are the largest federally qualified health center system in the country. So we've got about 70 clinics. If you sort of include all in medical and dental and our school-based sites, et cetera, which means we really have a vast population from which we can potentially support the contribution to clinical trials, various other research that's about ambulatory care. The majority of our patients are Latino or Asian American. Many represent kind of smaller groups within the Asian American community, like Hmong. And so we really do have a unique vision on not only how can we contribute, but what are the barriers to involvement across these different groups. So I can tell you that one of our most recent challenges has been about a blood sample program related to a large national collection of data to just really contribute to larger databases and not specific to any pharmaceutical company or drug development. But it is incredibly challenging to frame the value of participation for our approximately 500,000 patients when we think about the real and living and breathing history of damage, not just theoretical damage, but damage that kind of keeps popping up that our community feels from the scientific and medical community. And I want to just sort of frame this within, have you ever hurt yourself in some very minor way, but like maybe on your wrist or your hand or on your hip or something? You never really think about the injury if it's not that big of a deal until you lean on it. And then you're like, oh, wow, I have a bruise there. Yikes, I totally forgot about that. That's pretty much what it feels like to grow up Latino, at least in Southern California, where we have a legacy of, I want to say, pressured / forced sterilization among our women. And so in the Latino community, about 1.5 miles from here at County Hospital, during the 60s and 70s, Latina women who were there during childbirth were either sterilized against their permission or were pressured strongly to be sterilized. And so I grew up as a Latino in Southern California, as a Latina, hearing these stories and knowing that if you go to county, you probably don't want to give birth there. But is it real? I don't know. I'm growing up hearing this stuff. I'm not a scientist yet. I'm not in college. I don't know any of that. And then when I go to college, I meet somebody who's part of this documentary film, No Mas Bebés, that's about that sterilization project. And it's like I just leaned on my wrist and I felt that bruise like, ooh, oh yeah, I guess that thing was real. Yikes, that's really scary. But you put it away a little bit and you go about your business, you get your degree, and now you're a scientist, and then you're sitting at your table and you hear about the same thing happening in Georgia at a detention center in 2020. And all of a sudden, I'm leaning real hard on that wrist bruise. It's this stuff that never kind of goes away. So we talk about recouping trust and getting our folks to buy into these programs, but the potential for damage is always there. It's always around the corner, and all it's doing is validating these deep feelings that prevent our people from wanting to give you a blood sample. And not only are we dealing with it at this sort of, I want to say this is a heightened participation in your healthcare, right? You're going beyond just getting the frontline treatment. You're actually trying to contribute to the science and our discoveries, right? But just going to the clinic, depending on the experience that you have, we don't know if that's our one touch point that we get with you for the year or maybe for 6 years. So we're trying to do every single thing we can while you're there, which means you're being asked a bunch of things, your entire history, you're having to go through very sensitive things, sometimes in 15 minutes. And the ability for us to bring you in, help you feel supported, listened to, and then also talk to about maybe getting deeper in with something like a blood sample, it's a pretty big ask. I will say that beyond that, it's a big ask for our providers, most of whom represent the communities they serve. I grew up here in Northeast LA. That's why I know the story about county, right? And so there is an additional tax for our folks who are trying to be boosters for this work when they themselves are walking around with those bruised wrists, kind of waiting for the next thing to come into the news. And so I think that when we talk about compensation or we talk about support, and I was really excited to hear very specifically, a few people talked about this, Jennifer, Dr. Pimu, both Jennifers actually, this idea in terms of capacity building for funding for clinicians who are willing to promote this. That's the reality. It's not just the compensation for the additional education. It's not just the compensation for the lost time because we're not generating billable units, but it is somehow the compensation and reconciling for the trauma that most of us grew up with. And you have to convince me to be okay with that story if you're also going to convince me to convince others. And so lots of thoughts on this panel. I really, this moved me so deeply. And I want to thank everybody who spoke here. And I'm happy to answer questions about FQHCs, some of our challenges in that trust building, and what we can do when the majority of our providers represent the communities they serve. Thank you.
Thank you so much. And I hope we'll have some time to touch on several of the things that you brought up in terms of trust. I'm also thinking about eugenics and some of the sterilization also in North Carolina that we had, and just how do we lay that foundation. But thank you so much for those comments. And I hope we'll definitely be able to circle back and really dig deeper into that. And next we'll have Michelle. Thank you so much. And we'll have Michelle come on. Thank you.
Hi, nice to meet you. My name is Michelle Reed. I'm the head of our clinical trial diversity efforts at GSK, and we call ourselves Global Demographics and Diversity inside of our clinical operations, because there's a lot of focus on race and ethnicity today, but there's been wonderful conversations throughout the session today about all demographics, not just race and ethnicity. You know, we're talking about age, we're talking about sex, we're talking about gender, we're talking about disability, and all of the inclusivity around all of those areas. At the manufacturer, I know there's been such a wide range of folks involved today, but you know, coming in from the perspective of a biopharma company trying to do the right thing in this environment, you know, over the last 15 years, GSK has learned to apply the science of clinical trial diversity, and we didn't have a process in place all the time. And that was widespread across the sector, all the industry. Everyone is learning how to do this, right? And many studies that we've enrolled, we enrolled with whomever showed up or whomever was willing to do that. And that was not always in the best proportions. And in fact, in recent history, some of the products that GSK is famous for did not initially enroll enough people from underrepresented groups. But we realized that that was important. And in some cases, we were required to make that right. And in other cases, we saw that it was best to make that right and for scientific discovery. So we learned what we could do, and we've been, especially, you know, in the last few years, and I've been in this position for 2 or 3 years now, to really encode what we're doing and make it business as usual. And what's been really incredible is over the last few years, just the last couple of years, in fact, all of the pharmaceutical companies have started to understand that we can work together. And there's a phrase that was mentioned earlier in the session today about the idea of islands of pilots. And I thought that was, I resonated around that really well, because we can't make enough critical mass to move forward with people. And Adrian's comments about, you know, the Hispanic community, Hispanic Latinos, and in the United States with the Black and African American, or myself, who I would love for somebody to try to guess what I am, because I'm ethnically ambiguous. What boxes do I check? Several, right? How do we use that? How do we learn from that? So we do that better. At GSK, you know, we've learned what we can do better. We've learned that it's important for everybody, especially the patients, to do better. So we've been making public commitments regarding clinical trial diversity over the last few years, beginning with the notion that what you measure is what matters. And from that point of view, we have some North Star ideas in mind. So as a biopharma company, we can't crack the lock on health equity at large all by ourselves. That's that whole islands aspect. But we can start breaking some of the bad cycles that have existed for so long. One of the most concrete things that we've done is to ensure the representation from an epidemiological point of view. And that can be really unusual for a company like ours, who has a wide range of, we have medicines on one hand, which epidemiologically that's fairly straightforward to understand who's dealing with those situations. Then we have vaccines, and that's also difficult for that. So that's what we're trying to make sure that we understand how that is. At the end of the day, we can break some of those cycles and allow physicians and also patients to understand, hey, I feel confident in my medical decision making because I can see myself in that data, and I can have a better idea of how this will work for me as an individual. So thank you for having me.
Thank you so much. Thank you so much, Michelle. Next, we'll have Barbara.
Thank you. It's really hard. I mean, it's a privilege to be part of this conversation, and it's really hard to know what to focus on. So, and it's changed with every panel, I have to say. So, and I think I'll just take a step back. My name's Barbara Beer. I'm a professor of medicine at Harvard and the faculty director of the MRCT Center, which is a research and policy center at Harvard and the Brigham that looks at the ethics, conduct, and regulatory environment of multi-site, multinational clinical trials. We've been working on this issue for, I don't know how long, a decade. And it's reassuring to see so many conversations about something that was so difficult to talk about and so unpopular 10 years ago. So that itself is has moved the sort of discussion forward. A lot of the discussion today is focused not entirely, but primarily on pharmaceutical trials. And I do want to say that I think all of this has to start way earlier, not just at planning instead of at results, but rather in the preclinical arena, to biosamples, to genetic diversity, to all, you know, sort of the through the phases to post phase 4, and then clinical effectiveness, real world data. And it's the continuum, because all these questions we can't answer at any phase in that trial. And we need to be attentive throughout the sort of life cycle of our understanding of interventions to promote health. There's also a variety of settings at which this is done. You know, from academic medical centers to clinical research environments and in the community. And all of that does require sort of thinking in a much more nuanced way about how we're going to approach these trials. What we've heard, and I have to say, I agree with everything that's been said today, but it's interesting that, you know, we've sort of punctuated many of the things we need to do in a future-oriented way with different examples and different sort of ideas of what would make change. Who is responsible? Everybody's responsible. Who should pay? Everybody should be invested in making this. And it resulted with, you know, from staccato efforts to engage everyone in a plan, to 4 organizations coming together to say, we need a national agenda, a national action plan for this. So that was the MRCT Center, Faster Cures, and Milken Institute, who we heard from Amanda today, Carolyn Shore, who you'll hear from in a minute, and CTTI, the Clinical Trials Transformation Initiative, who you also heard from, to sort of create a national agenda and a national action plan, which we've had 3 convenings around, and we'll have 1 more, and then continue to sort of really operationalize 8 domains with specific examples of the kinds of things that we can commit to. And when you see it, you'll see that everybody's reflected in that. Everybody has a role in it, and everybody should be able to find themselves and their actions in those action plans. I will say a couple of voices that I think we do need to hear from, and some of that, you know, in the last session, which also was incredibly compelling. I'm not a huge enthusiast for incentives when I think we've been doing wrong for a long time. I think we need to be doing it because it's the right thing to do, not necessarily incentivizing behaviors that are we shouldn't have tolerated in the first place. I do think that FQHCs, for instance, HRSA should be in this conversation. You know, the cap on your overhead, I'm speaking specifically to Adrian, is a problem. If you really want to lift FQHCs and other community centers to be able to deliver this kind of care and or research and to have that, they should be here. CMS should be here because the coverage that they provide is limited to life-limiting, life-threatening situations. And that's a problem because a lot of research is not defined. It's around common conditions that aren't necessarily immediately life-threatening and therefore don't necessarily sort of fall into that bucket. And I'll bring up one other thing that I feel very strongly about, which is that we currently disincentivize people to participate because compensation, when it's allowable, will threaten their entitlements. And, you know, it's very minimal money, but the problem is that it's a real disincentive for people. If they lose SSI, you know, that or SNAP or you know, CHIP, that's going to take them months and months and months to get back. And we should be working at all the sectors to try and find the solutions to make this possible. And I've just been forewarned that I'm at time, so I'll pass this over to Carolyn.
Thank you, Barbara. So my name is Carolyn Shore, and I direct the National Academy's Forum on Drug Discovery, Development, and Translation. And this is a standing body of the National Academies. It's been ongoing since 2005 in its current state, and actually was established in an earlier form back in the 1980s. We're a membership-based group that tries to identify critical issues, opportunities for cross-sector collaboration, and opportunities for action to help improve the life cycle of drug discovery, development, and translation. Areas that I think are particularly relevant for this conversation that the forum has taken on focus on areas around enhancing representation in clinical research. As other speakers have mentioned, you know, this goes beyond even just race, ethnicity, gender, but can include other underrepresented populations. For example, pregnant and lactating persons, people with highly prevalent chronic conditions, adults across the older age span. Our approach has been to convene stakeholders in a public setting to help folks, you know, identify some of the opportunities and also some of the challenges where there could be cross-sector and or collaborative opportunities to address some of the issues at stake. As Barbara mentioned, you know, we have been in conversations with the other three organizations that she mentioned when thinking about systems level change as it relates to improving representation in clinical research, clinical trials. As part of that effort, the forum will be co-hosting a workshop on May 20th on this topic. It's open to all comers and will be available for those who want to participate in person or virtually. And that really does build on a series of meetings that have been hosted by City, MRCT, as well as Faster Cures, and of course builds on many decades of experience, many of the contributions from folks who have presented earlier today, in fact. Another area that I think relates to this topic is work that the forum has done around site enablement. So thinking about ways to reduce some of the inefficiencies, redundancies when it comes to basic qualifications for setting up a clinical trial, and thinking about site readiness practices that are generally shared across different sites, and that can include not just traditional medical research centers, but also community practices, community health centers, community hospitals, to help enable those different sites to assess their capacity to conduct a clinical trial. And setting up a flexible framework as a model for supporting site development, just recognizing that there are many different ways of conducting clinical research, highlighting particularly non-traditional clinical trial sites, and thinking about, focusing on the strengths of particular locations, for example, rural locations or smaller community-based clinics and what they can bring to the table. And I think, as many of our previous speakers have mentioned, the idea of co-creating solutions with people who are on the ground and carrying out the work. The last piece that I'll mention that the forum has worked on is around workforce, which was mentioned earlier today. We held a workshop back in October, and a lot of those conversations focused on both collective efforts that can only be accomplished through cross-sector partnerships, but also individual efforts, either individual organizations or even individuals, individual people, like what can be done to help build towards common goals when it comes to addressing issues with the lack of trust or trustworthiness on the part of institutions or on the part of clinical research as a whole. And thinking about sustainability as it relates to, the folks who are on the ground doing the day-to-day work, and also the institutions that have bottom lines that they have to adhere to. Across all of those efforts, some common themes that we heard is that, a lot of these do require co-creation, partnering with communities and patients, so that, as Barbara mentioned, that people are at the table, not at the end of the game, but from the very beginning, defining what is of value and what is important. Reconciliation for past trauma, that was also brought up in many of these conversations. So it's not just about dedicated funding and line items, which is critically important, but also considering what is just as well as what is equitable, and recognizing that doing the right thing may not be the most efficient path. I'll hand back to our moderator.
Thank you so much, Carolyn. You brought up some amazing points. All of you all did. And I know you've already started to really talk about some specific actions, but I did want to open it up to the panel. I know you all have talked about the different organizations that need to be brought to the table, trust and trustworthiness and rebuilding that, community partnerships, looking across the board at accessibility, race, gender, all of those things. But just wanted to see if anyone else had any more comments or any more input on what specific actions do you believe are necessary to translate today's discussion into tangible progress towards greater diversity and inclusion in clinical trials? And I'll just open it up to the panel. Thanks, Barbara.
So I just want to bring up one other thing that we haven't touched on today as much, which is I want to be thoughtful that when we sort of try to build out our diverse representation, we don't do that at the expense of other countries and other sort of communities, and make sure that we're not transactional in sort of picking up Black people from Africa or Hispanic people from Latin America, that we're very thoughtful about respecting the cultural integrity of those settings in which that do participate. I do think that what we need is a few things. We need to be way more intentional about sort of the data aspects of this, both having common data, and I know people are working on this, interoperable data, but data where we can track where we're doing well and where we're continuing not to do well. That's both in terms of the distribution in clinical trials, but more importantly in health disparities that sort of are only measured at the very, very end, and of course have lots of different factors that contribute to them, but we don't do that particularly well. I also think we have to be very thoughtful about how we, how we invest the funds that we will have, because it's not like we have unlimited funds. They have to be targeted in a way that is going to be impactful. And that should be community driven, at least largely. And I do think that having a sense of where we're going nationally will be helpful to our efforts. I don't want to use up all the time. I can keep going, but go for it.
Can I add something here? I think there are a lot of specific actions we could be thinking about. And I think if you think about it from a really holistic perspective, it has to start with the science and the protocol design, and then that has to flow through into the operations. And I can't be exhaustive here, but I think I can identify 3 different pieces that we've seen that could be potentially valuable to think through. The first one is designing the protocol so that it really matches the underlying population and not just the population that we may see in academic medical centers. And I'll give you an example, is that we received a protocol, and patients in the protocol were taking a specific dose of a medication, and this dose of medication wasn't standard of care. And when you apply that dose of medication onto the patient population, you go from tens of thousands or hundreds of thousands to just a few hundred. And that has really, really big implications for the types of patients that may that may be eligible for a study. And so the protocol design shouldn't just be cut and paste with the science in mind, but we really need to think about the patient journey, and the patient journey, not just for those patients that we see in academic centers, but really in the United States. Another important point to think about is health literacy. In Walmart, we have 68 million patients in our pharmacy. And to a large extent, we see patients who have lower health literacy. And it's very, very important that when we're thinking about the operations of the study and thinking about how to identify the patients that would be eligible, that we're able to create the language in a language that resonates. And what we see a lot of the time are screeners that are cut and paste from very scientific, complex, technical protocols that our patients don't necessarily understand, and that, even people with PhDs and MDs may not even understand. And so what that means is you lose the opportunity to engage patients who would really truly benefit from that medication, because they just don't understand how to get from stage A to stage B. And then I think also really thinking about the diverse data sets that we can use to identify where the patients are and where the site should be and where the research should be conducted. A lot of the time we see sites being placed in the areas where you have a lower representation of the patients who represent the underlying epidemiology of the disease. And I'll give you an example. We put a protocol through our system, through our patient system, and this was a protocol that the sponsor was having difficulty with because there aren't that many patients out there. But because we have such a large patient population, we were able to find around 35,000 patients. But then when we overlaid the sites onto it, there were less than 3,000 patients. And so we're really missing a very large population when we don't think about matching the infrastructure with the underlying diversity. And then I think that the last thing to think about is if the patient voice is not represented in the clinical trial, then we really have to make sure that they're represented in the real world evidence. And that's really a focus right now of WHRI, which is the Walmart Healthcare Research Institute, thinking about how do we develop real world evidence studies to give our patients a voice where decisions are being made, because they may not have been represented in the clinical trials. And it's very, very important that we understand the safety and effectiveness of the medications in this patient population in the real world.
That's really fantastic contribution. So I was thinking back to the activities that the forum has hosted over the years, and I would say there are sort of 3 buckets of action areas that we have heard in all those different venues that I had mentioned. So one is actions around scale up of ideas, pilot projects. I think others have mentioned, you have 1,000 flowers blooming, but how do you incorporate that into a national level action plan, or establish a framework that's going to work for other types of organizations? And so, kind of actions around figuring out the practical steps on the part of policymakers, funders, and or implementers who are carrying out the research to move from a pilot project to a scaled up initiative. The second, others have mentioned before, which is, how do you integrate practices into business as usual? So thinking about this not in terms of the champions that we thankfully have in place who are really pushing for action and prioritization of many of these important and critical questions, but rather integrating that into the practice of an organization, whether that be an industry, in government, or an academic research institution, or a community practice. And so, there are lessons learned from, again, examples of success, and also examples where maybe things didn't go as well as they should have. But thinking now where there's this kind of national spotlight and attention on this issue, and making things sustainable and part of the business as usual. And then the third area that I have heard is around incorporating the perspective of communities and patients and their health values, starting with the research question. So going back even further up the chain, so even earlier than developing protocols and carrying out the research to what is it that communities and patients really care about. What are the outcome measures that are of value to them, and therefore, tailoring the research that comes afterwards, based in part through co-creation with folks who are in the community and or who represent the intended patient populations that future medical products are intended to serve.
And I will add that, over the last number of years, there's been much greater partnership across multiple sectors, including across the pharma industry itself, working with sites, patient advocates, CROs, IROs, academia, etc., and bringing in a holistic, pre-competitive and very positive sort of attention to this. So I do think that we're at the precipice of real change, but it's institutionalizing that change and making it, as we say, business as usual, tracking those outcomes, and then making sure that we're having the effect that we want in the long term. I do think that as a community, we, as Adrienne says, and others, we need to own our past, but also be transparent about our future. And the more that we share what we're doing and how we're doing it, how we succeed, how we fail, the better it's going to be.
Thank you so much. Oh, please go ahead.
Oh, I'm sorry, Selena. I'm resonating on the collaboration elements here, because the discussion around how to make it self-sustaining and how sites can actually stand up and have a business plan that doesn't fall apart if one study finishes or goes away, and how can a site think of themselves and hire staff and bring investigators in and then have a long runway for that forever. And so there's a working group right now looking at sub-Saharan Africa, because if we have an infrastructure here, there's infrastructure in Africa as well, but there's really not a lot of sponsorship activity for a variety of reasons. But it was an interesting case study because just applying that here, the aspect of collaboration with multi-sponsor scheduling really comes into an interesting place. We had some snapshots we did within our own doors to say, okay, well, just narrowing down the focus, let's look at the historically Black colleges and universities. There's only 3 schools that can matriculate a physician here in the United States out of the HBCU, Morehouse and Meharry and Howard. And there's 3 on the way, and that's great, but it's still only 6. And so we're looking back and saying, okay, in this snapshot, how much activity did we have in that network? really not very much. Okay, let's find out why. And part of it was the mismatch between the protocols that we had available and the research initiatives that were going on in those institutions. You look at a school like Meharry, and a shout out to Meharry, who is doing incredible HIV research with an incredible lab there. They had actually closed the doors on their oncology work because the staff and the protocols just weren't there, and that made sense. But that's not like the oncology pipelines in our manufacturing organizations are dead. so it's a really interesting conundrum to make sure that there's matching taking place with these organizations in these wonderful catchment areas. And then that goes back into the data, frankly, and another shout out to Satcher at Morehouse because of the health equity tracker. And they come right out and tell you, and go to healthequitytracker.org. They tell you that the data in minority populations, and I can't recall if it was Barbara or Carolyn or to say that there is a lack of data, and the missing pieces in that data in our underserved communities really gives us the wrong picture as to, it looks bad in the data, but it's even worse than that because it's an incomplete data set. So there's some work to do. I'll leave it at that.
Are we going on to the next question, or can I weigh in on this?
Please go ahead and weigh in.
Okay, just to circle back on what Barbara and Carolyn said, and I guess also to include a little bit of what we just heard about in terms of the medical schools. I think what I've found to be the most important for any sort of participation in research in our FQHC settings is that patient and provider is a false dichotomy. The majority of our providers come from the communities they serve. The majority of us went to FQs as kids, or experienced food or housing insecurity, or struggled as first-gen high school grads to get to where we are. So when we are being engaged by R1 institutions, we're often talked to as though we're one of them. You're a scientist like us. And the expectation is that we've already bought into everything that you're showing up with. And we're on your side, we're on your team. When really, I have experienced very few true scientific partnerships when I have been in a health sciences space, a health services space, either in ambulatory care or in a hospital, and I've been approached by a scientist and they've wanted to collaborate on a study. It is so rare that they want more than my clinical credentials to be a part of that study. And it's something that we're actively confronting right now at Ultimate, because we have illustrious, partners, but is that a mismatch to get somebody who is like a, fully tenured professor of epidemiology from Duke working with somebody who just got out of residency, who maybe doesn't have the research experience, and you're asking them to sort of sponsor your project internally in our organization. So I think it's important to take a step back when the folks who are doing sort of the foundational research for these clinical trials are approaching these health delivery spaces and making sure that is there equipoise between the two people that are on this proposal? And if there isn't, what can the academics do to maybe help the other folks get up to speed, make sure that we're in alignment, make sure that any trauma or past history has sort of been addressed so that we really can advocate for you in this space? Because I think that there is a big difference between the folks that are generating the knowledge and the folks that are implementing it on the ground. And it's more than that 16 years of delay. There are philosophical and experiential differences that make that a huge chasm before we even start talking about the patients.
But it does go back to the first panel, which is these interactions, engagement can't be transactional. It can't be performative. It needs to be sustained and long-term. And that is exactly why the funding model and having, sort of cooperativity is really important. I mean, in Boston, we have 10 hospitals that compete for community engagement. And I'm like, this is crazy. We should be aligning to involve the community, not competing for the community attention. It's a problem perhaps that's unique to this over industrialized environment that I live in, but nevertheless. So I do think there's a lot there that we can sort of work on. I also think that we shouldn't forget all of the ways that we make our work harder. So when the NIH was funding some of the sort of community-based research during COVID, they asked, first of all, for Social Security numbers. You can't ask for that and expect people to contribute. You can't. They were asking for different demographics and a different list than the FQHCs were connecting, were already filling out for them. So that's double the work. And we're trying to fit it in when FQHC physician and caregivers were dying with the work. No, I didn't mean it like dying, but also dying. And when pharma asked the sites or academic medical centers for the same data in a different format, it triples the work. And when we ask, so we could do this better as a nation. And we could take a lot of the administrative pieces that don't really change the outcomes, but make it tougher to get it done as a system. So we have a framework.
We really do. And I think that was just the perfect note just about how to really move forward and what we really need to look at and address. You all have been amazing. We could go on definitely for another hour, but I just want to thank you all so much for this wonderful session. And now I'll turn it back over to Trevor Locke for closing remarks. Thank you all so much.
Thank you.
Thank you all so much. That was great. It makes my job closing us out much easier. I don't think I need to summarize much. I think that last panel really nailed all of the key points that we've heard throughout the day and added in a few more. So I get the fun job of thanking everyone. First, thanks to all of our speakers and panelists who took time out of their very busy schedules to come share their experiences and insights and expertise with us. As you saw, there is a lot going on in this space, and in the weeks and months to come, we'll hear more and more about great work in this space as we all keep working together. Second, I want to thank again the Robert Wood Johnson Foundation, whose funding support made our work here at Margolis on this topic possible. And of course, would not be possible without our great team here at Duke and Duke-Margolis. So thanks again to my fellow moderators, Salima, Marianne, and Sandra, as well as our other project staff, Andrea Toomey, Luke DeRocher, Matt DeRogio, Cameron Joyce, and Valerie Parker. Would not be possible without their help and contributions today and over the past several weeks. And of course, as always, thank you to all of you who have joined us today and stuck with us to the end. We appreciate your being involved in our event, and thanks for joining in on the polls throughout the day. As a reminder, we'll again have the recording of this up sometime next week if you want to go back and catch any of the conversations. Thank you all again for joining us, and have a great rest of your day. Take care.